good student yesterday, so I enjoyed the time yesterday. And the second part is that you have been gracious enough, including Moni's session, pleasure to meet Moni as well yesterday, that you have allowed me to prepone the talk only because I have a flight to catch. Now, the brief given to me is to speak on artificial intelligence in surgical oncology. Can we have the first slide, please? Yeah. So, difficult topic, but it's here to stay. And let me try to take you through a journey which all of you would largely know. But to just briefly recapitulate, we have this concept of evidence-based medicine. At the Tata Memorial, we started these EBM meetings in 2002 when I was just joining as a consultant. And we clearly know how evidence-based medicine has evolved and how we should ideally be practicing our medicine so that we are not over-treating our patients, we are optimally treating our patients in a human way. But then, of course, we've always felt that the best levels of evidence, regardless of how much of that gets implemented into day-to-day practice, unfortunately, but that does not change the original science. And then the answer has been that you require randomized controlled trials. And my brief is to speak of surgery, not for medical oncology or radiation oncology. So they are desirable, but there are enormous number of challenges. You see this. So that's why surgical trials generally will suffer from poor accrual. Interventions that are being tested, they can't be easily standardized. Clinical equipoise, superiority or inferiority is another question that you need to address. In the non-operative arms, you will always have less accrual. This is understandable. There are other challenges in terms of they being resource intensive. Majority of them would be investigator initiated, they won't be industry initiated. They will take years to complete. So we have a whole lot of challenges when it comes to RCTs. That has resulted in we looking at big data. Collaborative studies across centers, studies across countries and continents to try and see whether we can get some information based on day-to-day practice. And this is widely accessible. Outcomes research is something which is great, it is cheaper, it is faster. And of course, it's real world, and that's the reality in which we should live. So on that background, yes, I think big data and RCTs in surgical oncology, they can impact, at least in HPB surgery. This is something on which I had to give a talk in Great Britain a couple of years ago at the HPB meeting. And that's where we looked at a whole lot of day-to-day clinical scenarios, for example, in hepatopancreatobiliary cancers. And you can see that a large amount of work that we do in HPB is largely based on big data, sometimes good, sometimes not so good. That's why you require big data first, and then you are able to continue your daily practice. Also challenges our generation and the next generation to do more research to try and achieve higher levels of evidence. Now we come on the background of all this that is going on. Day-to-day practice, training, learning, understanding what is EBM, trying to live up to the expectations of EBM, trying to do RCTs, and then now you are bombarded with this concept. For the younger members, I think, I've had to learn, perhaps all of you know this, it's the ability of a machine to perform tasks thought to require human intelligence. It's based on reinforcement learning. It revolves around the usage of algorithms, and it involves identifications of patterns and reinforcement. These were the three gentlemen who kind of initiated the concept of artificial intelligence. And then you have, how do we go about it? The basic concept is big data. Again, you can't ignore that. Input the variables. And then you have machine learning, so you have pattern recognition, you build algorithms, and then you further reinforce and redevelop or redefine the algorithms. And that's what it is about: artificial intelligence, machine learning, and then deep learning. These terms can sometimes be intimidating, but if you try to study them more closely, they are actually not. It's our brain which has finally put in this concept of artificial intelligence. And without realizing, in a subtle but a sure way, it's already here. In every sense that you think of, this is all AI. and we experience it in our life on a day-to-day basis. But now let's look specifically at AI in healthcare, and I want you to focus only in the last column of this busy slide. Conventional practices, clinical presentations, and then clinicians' judgment, electronic health records, documentation, and then decision making. And then conventional decision support systems, which we all do in our practice over a period of time, is that we have these algorithms which also help us to take our clinical decisions, and algorithms are based on the electronic health records that we have. But the last two sections are the ones where we are moving in the direction of artificial intelligence. The C part is where you can see that the algorithms are going back in the electronic health records. This is different from B. And in the last one, there is no human being involved. So we will talk about this, where you have fully automated clinical systems, but the focus is to try and improve on the conventional decision support systems. A and B already exist. C and D is a story which is in evolution. We have looked at some of these things. This is, of course, a review article. But I think, again, the ultimate aim of AI is that we can have better patient outcomes, whether it's pre-operative, intraoperative, or post-operative. So is it there in surgical oncology? I think it is already there in surgery, and it's also there in surgical oncology, and I'll quickly touch upon some of these. So let's look at path diagnosis, radiology, anesthesia workup, AI in the pre-operative management, as well as risk stratification of patients. It's exactly based on ABCD, which I showed you as far as AI in healthcare is concerned. Look at this. I'm not going to study into any detail. I'm just going to highlight to you that you have deep learning systems which detect dysplasia with human-like accuracy using histopath and profile-based confocal laser endomicroscopy. So you have these deep learning models which have achieved high accuracy. For example, here in esophageal dysplasia and its precursor, it's as good as human accuracy. So it's coming, it's here already. What about preoperative imaging? This is something which we started off long ago, even when I've been in Tata Memorial for 24 years now. And when it came to Merian software or knowing about the future liver remnant and planning surgery, when I was in Heidelberg doing my Warren Fellowship, at that time something like this for better localization and virtual simulation surgery was already existent in 2005. It's just got more and more refined, that you have a complete roadmap. It's very similar to what we see on a Google map. You can study everything before, satellite image, etc., etc. Your brain is wired better when you go inside the operative room, and then you are able to treat patients better. Endoscopic standardization, look at this, real-time differentiation of adenomatous and hyperplastic diminutive colorectal polyps during analysis of unaltered videos of standard colonoscopy using a deep learning model. And again, they are able to augment diagnosis in real time. So it's making its inroads. What about pre-operative risk stratification? I know NASQIP is not great, but on the other hand, that's the largest system which you have in a country like America, where things do get documented and you actually get real world evidence. And again, you have a development and validation of machine learning models to identify high-risk patients using automatically curated electronic health record data. So it's a retrospective, single-site study, but again it says that it's more accurate than the ACS NASQIP calculator that's currently available. Can machine learning predict resectability of a peritoneal carcinomatosis? Sometimes when I read these titles, I tend to laugh as well. And yet then you need to again study it a little bit more in detail to think that no, maybe there is some method to the madness. I'm not convinced about it. But here you have 155 cases of patients undergoing HYPEC. Propensity matching, not the best thing to do. Many of you would know this. Of curative resections and exploration only groups, and AI detected possibility of non-resectability with 98% accuracy. I might say that I think we can detect it even without AI, But I should not be talking like this on this podium because we need to study this, we need to challenge this, we need to test this to really know whether that's true. Artificial intelligence and surgical decision making. You have this as well. It augments our decision to operate. So again, remember A, B, and C and D, that's where I'm focusing mainly on A, B, and C as of now, where the clinician or the human being is still relevant. So this does augment your decision to operate. It streamlines your informed consent, an ever-changing field. You are able to identify, sometimes mitigate what you can modify as risk factors. And of course, you can recognize and manage complications better in the modern era where you have challenges of teaching, connectivity, etc., when it comes to teaching a complex art like oncology. This is a randomized trial, unblinded, machine learning, early warning system compared with standard care, small number of patients, but significantly less hypotension episodes with machine learning. So now you have something which can guide your anesthesia during elective non-cardiac surgery, but it's a randomized trial, so you can see that we are getting better and better with AI. Same thing applies to perioperative fluid management. See the conclusion here. Fluid bolus is recommended by the software, resulted in desired stroke volume increases more often and with greater absolute stroke volume increase than clinician-initiated boluses. Automated assessment of fluid responsiveness may help clinicians optimize intra-fluid management during non-cardiac surgery. So these kinds of things are affecting us in every aspect of our lives. I already told you in terms of pre-operative mapping, but you also have a navigation system which is intraoperative in the robotic era. So you have a navigation system for open liver surgery in this particular paper, and though experimental at present, AI-directed navigation surgery could be the future for complex operations. In other words, you actually are able to see through everything even before you do it. So not just pre-operatively, but even intraoperatively. Why do accidents or why do some of these complications happen? They happen not because surgeons want to create complications. You are completely lost in a jungle. You bring in your experience, you bring in your higher levels of anticipation, your spinal learning, your hours of work, and yet you will land in difficulties. That's how the human body is. If you're going to get a roadmap which is going to be even better than pre-operative, nothing like it, it's going to make our life easier. Pancreatic resection, something which is close to my heart and I've constantly kept on evaluating. I keep on telling myself, you're as good as your last operation all the time. And here you have the possibility of being able to again acquire your intraparenchymal landmarks, intraparenchymal for CT and sonography to a 3D model registration. And then you have a 3D image-guided resection through the pancreatic duct. So you can really make your job easy. This is all modern technology, which is actually making our life easier. I would still say in a complementary fashion. That's my opinion, but I stand corrected. We will see. Hopefully, Aju invites me 5 years down the line, and I'll see whether I can improve upon this. We learn something from this, we get worse or we get better. Augmented reality is there. Again, I told you, you have a CT scan, you have a surface rendering image, and you see what happens in the operative field. A cirrhotic liver, I want to know where the cava is. I want to see all the hepatic veins. These things can kill patients, as you know, who are in the world of surgery would know this. And then you have a complete navigation, which is going to augment how things go on. Now, you also have another study which shows, I'm just explaining to you the spectrum of possibilities. So here you have a recognition of surgical, this is sigmoidectomy, colorectal surgery. Again, a common cancer. Oncology is in a big way as far as colorectal is concerned. And you have recognition of surgical phases and actions. The accuracy is more than 90%. It's possible to detect occurrence of intrasurgical events and to avoid near-miss events. And you have been able to divide these phases into kind of 7 phases, starting and ending. So you can see that, again, artificial intelligence is going to be guiding you towards safer surgery, but not just safer surgery, Perhaps it has possibilities that you can also use it as a teaching aid. Head and neck oncology, 33% of the world's cancers of the aerodigestive tract are unfortunately in our country. So I can't go away from this, though this is not my specialty. Moni is very much, of course, there. So zygomatic implants, for an example, offers a solution for patients with severe maxillary bone loss, often after tumor removal in head and neck cancers. AI is going to provide you proper positioning, alignment by dynamic navigation technique. All this is only occurring due to AI and the technology we have. Post-operative risk prediction, I still continuously believe that it's the human being which will detect, anticipate, and be able to, the philosophy of a stitch in time saves 9 will continue. So you can't take the human being out of the equation. Having said that, you have AI today for post-operative risk prediction. Just an example, this is there in every specialty, but I have just highlighted something for you as regards risk prediction platforms for pancreatic fistula after Whipple resection, where you have calculators, where you have ways that you can use these algorithms and large data to decide what's the best thing to do in an individual patient by just giving some data inputs to that. So you have this, again, available at your at the bedside. Same thing applies in the post-operative intensive care unit, where machine learning algorithms are already accurately predicting post-operative need for ICU care and avoiding fluid overloads or kidney damage. And there is also a potential use in pain management and drug delivery. A well-done surgery or a well-administered chemotherapy, but we actually don't know what all is going on with the patient. And the patient journey is perhaps the most important journey. So if things are going to enable us, even after we do a good job, to ensure that there is a smoother recovery, a healthier recovery, physically and mentally, I think we will all be leading much better lives than what we do. Robotic surgery is here. And then we know that it can give you enormous skills. It's a surgeon that never tires. The only difference between men and boys is that their toys get more expensive. So this is a toy. And I have no hesitation in saying that it's a toy. It's far away from evidence-based medicine. And I often ask this question, in which of these occasions would I use the robot on my own self if I have a problem? And I clearly know the answers. You can call me rigid, you can call me dogmatic, you can call me old, but I'm fine with it. So on this background, we know that it's a technology, which is an amazing technology. It gives you fantastic view, fantastic vision. It's a surgeon that never tires. You can sit by the console. You're not actually by the bedside. It's a different world. But you can train people. You can train people who don't get exposure. It's easy to say that learn pancreatic surgery in a high volume center. Of course, this is going to apply, and I'm deliberately taking the example of the most difficult operation to be done by the most difficult way, a Whipple resection by the robot. There are simpler, easier operations which can be done by the robot, where you can acquire your skills better, and in some cases, it will be beneficial to the patients for whom we actually exist. So robotic surgery simulation and training is something here where you can see that people have validated that simulation training significantly improved robotic instrument control. I think the timing is wrong. We have finished, how many minutes? I don't want to be late, couple of minutes more. So we have this simulation which is helping us. This was my own independent experience with Shafi Ahmed, a colorectal surgeon in the UK. Where I was in Mumbai on a holiday in Tata Memorial, and then you had somebody who is operating in London, and then there was somebody in Atlanta. That's my avatar. I could be in my office, and there's actually an audio for it, but maybe you have missed it. Doesn't matter. The key is that on a Sunday evening, I'm able to open through my HoloLens.
I'm here in downtown Atlanta, Georgia. I'm one of the creators of Thrive. Pleasure to be here today.
Thank you for joining us from the US. Shailash.
So,
hi, this is Professor Shailesh Srikhande. I'm the Chief of GI.
Now this has enormous learning possibilities. You can be anywhere in the world and yet you can be in the OR. But of course, again, I want to reinforce the concept that the main responsibilities of the operating surgeon in the operation theater in London. So it's not that I'm sitting remotely and taking the full responsibility of surgery. It's just telling you this has educational and intraoperative decision-making possibilities, etc., and all that is possible. Do we have some limitations of what we are embarking on and on what we have already embarked on? I think there are. Most of the algorithms are not validated today in the world of medicine. Errors are common, garbage in, garbage out. So it depends on what we really are putting in. AI is only as good as the data that is used to generate it. Data privacy and security are going to be challenges. Cyber crimes are already here. You will have ethical and medico-legal issues. I'm going to quickly close in 1 minute. This is something which I saw last week. I'm sure many of you have already seen this. A study from MIT in Boston, 54 subjects. They had groups where people used only the brain, no tools. Something was Google aided, and the last one was ChatGPT aided. And overuse of ChatGPT may reduce cognitive function. We are becoming slaves of technology. We get more and more dumb. There is no doubt in my mind about it. And the brain is actually a superb system created by the supreme creator, whatever you may believe in. And we are actually sometimes tampering with that very system, and that's going to confuse us. So thoughtful integration, using it as complementary to us, I think it's a fantastic asset. You have experts, and I was in Japan last week, and I took this slide, not the rest of the slide, but the top portion, where I'm watching and I'm reading this. Robots will surpass good human surgeons within a few years, and the best human surgeons within 5 years. I have respect for this flawed genius, and he could well be right. He's put something which I read in Tintin comics into reality, that you can have a starship which can go and land exactly the way you saw explorers on the moon when I read Tintin in my childhood. And this man has also created Tesla, whatnot. Do I agree with him? I openly stand corrected, but I don't think I agree with him. Our science is not so simple. I also am aware of another generation, those who are into liver or liver transplantation as a concept would know this. This guy died at the age of 91. The vast majority of his early attempts resulted in failures. There were challenges in America where there were suggestions to put him in prison for doing wrong and bad work. And this is Thomas Starzl, a very interesting book for you to read. But we must not forget that what was inconceivable yesterday and barely achievable today often becomes routine tomorrow. So I don't know. We will see what exactly is the situation. I'm not someone brilliant, but I know that you can't take away. In school we learn dedication, hard work, commitment, unwavering commitment. All these things do help us. It's not that in school they tell you be dishonest, work less, hard work is not important. I think these are eternal truths. So you require 10,000 hours of deliberate practice to become world-class in any field. I leave you at that. Thank you so much for your kind attention.
Thank you so much, sir. I remember reading The Puzzle People, and it says that the surgeon, Thomas Starzl, when he was training, he didn't have money, but his boss decided to come home for dinner, so he sacrificed one of his rabbits, lab rabbits. So it takes a lot of amount of training, but I was intrigued by one of your statements. I know what robotic surgery is good for, but you didn't say the rest.
In the sense that it should be a fantastic asset in the era of evidence-based medicine, and it's a continuation of what we discussed in one of the chats yesterday, that choosing wisely or common sense oncology. On one hand, I smile at it, that we have had to create this concept of common sense oncology and choosing wisely. Weren't we supposed to be doing that always, from the day we enter medical school? Why do we need to specify this, that our existence is on value-based medicine? So medicine is in the marketplace. For example, minimal invasive pancreatic resections, Michel Garnier did it first time in 1994. 31 years later, we are still struggling to establish equipoise and show superiority. You know what it means? That we are confused. We have so much data, we have so much talent, we have so much money, but we still don't get an answer. Because I think when you choose a wrong goal, as Einstein said, that perfection of tools and confusion of goals are the hallmarks of modern times. We get afflicted by robotic technology, you get afflicted by immunotherapy and so many other things which is totally different from the basic, solid, conventional chemotherapy on which your foundation is based on. We are human beings, so it's a question of our conscience, our science, and only then we can truly answer, because we get bombarded, and industry is already bombarded us completely. We are lost, confused.
That is a fantastic talk. I mean, not being a surgeon, I certainly never thought about all the AI aspects of surgery. But as you said, Elon Musk might be the first example of where common sense has been lost because of too much reliance of technology. But it's fascinating how much the imaging, as the imaging techniques get better, it would not be a problem already happening that you can walk into the suite with a virtual reality setup and
Absolutely.
you essentially know in 3D what your hands are doing. So the question is, maybe we won't replace the surgeon, but the distinction between the best surgeons and the average surgeon is going to disappear once we have those tools in hand.
Absolutely. So as a teaching tool, unbelievably good. A possibility to teach people based on that. But beyond the teaching tool, just the way you have had a huge challenge that something as basic as a laparoscopic cholecystectomy, the simplest and the most widely adopted operation in the United States, the biliary injuries unbelievably shot up when we introduced laparoscopic surgery. Now, after 30 years, you are now reaching a plateau where the injuries are not worse than what they were with open surgery. It tells us that you can be taught, you can have technology, but there are certain things which you can't really take away. And that's where perhaps not necessarily just the Malcolm Gladwell 10,000 hours for everything that you do, but that's relevant. Somewhere we should not get confused that that is perhaps less relevant, and everything that is being given to me, fed to me, spoon-fed to me, is going to make me fine. I think that's not happening. Whether it's test cricket, I play a lot of cricket, so I can tell you that you can't ignore the basics. That's what I feel. But as tools to learn and to grow, it is here to stay. We don't have to discard it. We need to more critically evaluate it, that's all.
Sir, excellent talk. I had a thought. Unlike us physicians, surgeons are excellent data generators. One of the things I was wondering is we use a lot of AI using images, including histology images, radiology, and actual pictures. But there's one thing I have not come across is video. And surgeons record a lot of video. Do you think there's a scope for having a video repository from which you could learn? And
Intuitive already has it. Intuitive has the data of every surgeon who does every robotic surgery if you're on their system. So I did my first robotic Whipple in November 2014. It's already there with Intuitive. They will see how slow I did it, how fast I did it, what were the things I could have done to optimize the surgery better, etc., etc. So they are creating a huge repository already. And this is just one example of Intuitive. So I'm sure this is happening all over the world all the time. So I'm not saying Elon Musk is going to be wrong. I'm very curious to see what's going to happen in 5 years. That's it. Sir.
Can I ask you one question?
Sure, sir, please.
One is, AI means what? AI means you're adding one more brain. That's all it means.
Exactly, sir.
So, people who have worked, say, 50 years, I have worked for 50 years, and I can tell you that when the patient walks in, I can smell the diagnosis. And when I talk to the patient, and patient speaks to me,
you know
from
it.
the history, 80% of the patient I will diagnose.
Now,
So it's only 20% that. What it means is that you are compressing the knowledge very easy and very fast. So the people who have worked only for 10 years can have the experience of 50 years.
so that's where I tell you, sir, that you said it. We had dinner together yesterday evening and we discussed this particular aspect. And I even told you that I'm going to tell people about this particular statement that you made now. And that's why I ended the talk about the 10,000 hours. Now the big question is the knowledge, the experience, the gut feel, the spinal level learning, the hard work of 50 years. We want to definitely, everybody can't be a Professor Advani and everybody can't be doing the kind of commitment and dedication for 50 years. The question is, are we able to compress it in 10 years or 5 years or 15 years or 20 years? And the other question is, forget what he did, I just have data which I can cull and I can become an Advani. I'm not sure about it at all today. But of course it's a creation of the human brain. AI is our creation. So I think it's going to be complementary. We must try to compress. Just because you took 50 years doesn't mean we should take 50 years. So that we need to check and test over a period of time. Okay. Thank you. Thank you so much.
Thank you, sir. As a token of appreciation, we would like to present a memento to Dr. Shailesh Srikanth, and for that I'm inviting Dr. Bobbin Thomas. Thank you, doctors. And next we have an intriguing topic, research in Kerala, what is the missing link? This session hopes to delve into the current state of cancer research right here in Kerala. We'll be looking to identify those key gaps that are perhaps hindering our progress and exploring strategies to cultivate a stronger, more vibrant research ecosystem. The discussion will touch upon how we can foster a culture of innovation and collaboration, and what essential infrastructure, policies, or even shifts in the mindset might be needed. We will also consider how the best practices from leading global research hubs can be effectively adapted and implemented within Kerala's unique healthcare context. I would like to invite the session coordinators, Dr. Arun Philip and Dr. Lakshmi Haridas, to kindly come forward and introduce the esteemed moderator and the panelist.
Good morning, all. So in continuation with yesterday's very fruitful panel discussions, we move over to the first session for day 2. And we know that despite a strong public and private healthcare ecosystem, we lag behind in translation research and generation of meaningful data. So this particular session, this forms the crux of the next panel discussion. And I think it is very apt that we have Dr. Moni Abraham Kuriakos to moderate this session. Sir is one of the handful of clinician scientists we have in this country at this moment. And he's currently serving as the medical director of Karkinos, Kerala. He's also a visiting professor at Roswell Park University, New York. And his basic fields of interest include head and neck oncology, skull-based surgery, and also he's also into a lot of basic research as far as head and neck stem cell, the etiology is concerned. So, and innumerable publications, and also he's got multiple patents to his name. I think it would be a very fruitful session under the moderation of Dr. Moni. I invite sir over to the stage to take over the stage. Dr. Lakshmi Haridas, professor at RCC Trivandrum, will be introducing the panelists for you.
Good morning, esteemed audience. We welcome all the panelists to this wonderful topic discussion for research, what is lacking in Kerala. Professor Chandrabas is the director of RGCB. He earned his PhD from Indian Institute of Science, Bangalore, an accomplished scientist with special interest in Raman and brilliant spectroscopy with research in X-ray diffraction using synchrotron radiation. Welcome you, sir. Dr. Vidya Veldur is a vice president of clinical operations at 4Base Care, which is a homegrown genomics company that has advanced precision oncology in Asia. She has extensive experience in clinical operations, cancer genomics, and the life sciences, including molecular biology, and her contribution to precision oncology aims at improving patient outcomes. Welcome, ma'am. Dr. Shaji Kumar is a clinician scientist at Mayo Clinic, focused in new drug development in hematologic disorders. Sir needs no extra discussions for his career. We already know him, pioneer in multiple myeloma and plasma cell disorders, author of innumerable original articles, and true academician cum scientist. Welcome you, sir. Dr. Sabi George is a medical oncologist with keen interest in uro-oncology, director of Network Clinical Trials at Roswell Park Comprehensive Cancer Center, and a part and parcel of several registration trials in uro-oncology, which we day-to-day refer. Welcome, sir. Dr. Aju Matthew needs no introduction to us. He is a practicing medical oncologist in Ernakulam, and his special interests are in epidemiology and implementation scientist. Over to Moli, sir.
Morning, can you hear me? Yeah, you can hear me. Hello. Good morning, and before we start the session, let me first congratulate Dr. Boban and Dr. Aju for creating a different type of conference we all really enjoyed, bringing people from different domains to come together to discuss some of the important issues. And this panel discussion is also not going to be different. As you have heard, we have people from different domains discussing about research. As the moderator, my responsibility is to introduce the concept and some of the pain points which the panelists can discuss. So to start with clinical, so if I'll introduce that, then these panelists will discuss the topic, and then we'll open up for discussion. Now, clinical research, when you talk about clinical research, lies at the intersection of basic science, clinical practice, and ethics. So in this panel, we had some discussion prior to this panel discussion online. So we're going to discuss clinical research in the lens of clinician, oncologist, as well as patient. As oncologists, we depend on data a lot for day-to-day clinical practice. But the point we need to ponder, where is the data comes from, whether it's relevant to the population we serve. We all know that cancer, when it develops, whether it's in Kerala or Kathmandu or Kentucky, cancer is cancer. There is no difference. But susceptibility to cancer or a response to the treatment or even implementation of the cancer access as well as affordability of cancer is different. So that data needs to be generated within the population we serve. So it's no longer a luxury, but a necessity. Now, when we talk about Kerala, we are in a very, very interesting type of population. We heard from yesterday's discussion. Now, Kerala is almost 10 years ahead of what is happening in the rest of the country because of the epidemiological transition. We heard yesterday that our incidence is about 200 per 100,000. Rest of the country is about half of that. And our number is almost half of what is happening in North America, where they come for almost 400 per 100,000. So we have a unique opportunity to bring up some data which is very, very interesting and relevant for discussion. Now, with the increase in cancer incidence, we also have increase in cancer care delivery network too. For a population of 34 million, with a crude number of about 80,000 new cancer patients, we have about 30 cancer centers, and number is increasing. When it comes to cancer research also, if you go to RGCB's new campus or Karkino's lab or wherever you go, we have amazing infrastructure too. When it comes to the oncologists also, number is also increasing. Now the question is, if you look at the research which has come out in Kerala, a lot of research has happened. Most of the research, if you look at it, mostly epidemiological research, or look at the early detection, or some of the pain and palliation research. And most of the research has come from public or regional cancer centers or some of the NGOs. Now we need to ask the question whether it has come from the larger oncology population or not. And what is the gap, what is the missing gap that is going to be discussed here. Now, one of the primary gap, if you look at it, is in the clinical trial. The number of clinical trials or transforming clinical trials coming out from the country or specifically from India is awfully lacking. We need to ask the question, why, what is the case behind that? So overall, if you look at, we have number of patients, we have infrastructure, and as well as personnel to manage it, but there are some definite gaps are there. So just to point out some of the important gaps, if you listed it out, maybe regulatory type of issues, those who have approached CEDESCO and looking at DCGI, we know the challenges faced by the investigator initial trial. Now, the second point is funding. If you look at the funding is the oxygen for clinical research. And if you look at the funding, most of the funding goes to basic science or even translation research. Hardly any funding come from the clinical trials. So that is something which we need to look at that. Yesterday's discussion, there was a panel discussion. We heard that in the culture of generics, the innovative type of research or high-risk research is not really rewarded. I'll give you an example. Now, about 4 or 6 years ago, I reviewed a proposal from a very good clinical research group on an induction immunotherapy in head and neck cancer. And that never got funded because reviewers thought that will increase the cost of the treatment. Now, we read 2-3 weeks ago about the Keynote 689 trial design, almost similar type of trial design. So that shows that we are not a high-risk taking type of facilities what we have. Now, the other issue we have is that the patient's concept about the acceptance for clinical trial, that is also a major challenge. There's a lot of taboo attached with that. That also we can discuss. When it comes to manpower, there are a lot of medical oncologists are there and also clinical oncologists are there in Kerala. The number is steadily increasing. And a large number of patients, almost 60% of cancer patients are managed in the private sector. But we need to ask the question whether the private sector oncologists are being part of that clinical trial or clinical research, and what could be the gap of that. That attitude also, we need to look at that. To address all these points, we have the amazing panelists, and they're going to discuss some of the issues in detail. So to start with, we're going to request Professor Chandrabas to talk about the translation research. What are the issues we are facing? Chandrabas, over to you.
Can I use the presentation?
Yes, sir, yes, sir.
Is the presentation on? Oh, okay. Oh, yeah, thanks. First of all, I should thank Dr. Moni for really thinking through this whole panel, and it's wonderful that he has put across each one's assignment, and I actually come from a research background, so I'm going to talk to you about translational research opportunities and challenges. This is something which is very, very important to understand. First and foremost, we need to understand what is translational research. We actually get into a muddle when we actually try to talk about translational research. When we are going through a drug or a procedure or a process, we need to do preclinical trials, then animal studies, then human studies, then it gets into the translation to patients and then to the population. This is what is the whole cycle of what we are talking about. But what is translational research? It is in between fundamental research and clinical research. It needs to bridge these two. These are two poles apart. If you think about fundamental research and clinical research, there is a big gap, and that is what the translation research has to bridge. And when we are talking about translation research, one of the most important thing which is missing is the leadership. And the leadership is very, very important. It's not an academic leadership. It is a leadership which is transformative, which means the leadership should be able to understand various aspects of clinical to fundamental research to what it takes to get the interdisciplinary areas of research which is there in the translation. This is to be very, very important to actually look at, and this leadership is lacking in this country. Management of projects and people is very, very important when you are looking at translation research because the time frame is fixed. We can't have a long-term goals for this. So we need to have a very good management of the projects. And there should be a very good communication between the various stakeholders inside this interdisciplinary area of research. When we go further, there is a lot of problems which come up when we are actually dealing with multidisciplinary areas. Is there has to be a regular, when we are treating diverse teams, there are problems of conflict, there are problems of having to do with stress management. All of these things require a dynamic environment which needs to be built up, followed by a collaborative and very good networking which needs to bring together multiple stakeholders at every platform to build up a strong team. Finally, we need to have defined roles and responsibility for various people, and each of these roles have to be monitored and well executed. If you can succeed in having this kind of an environment around, then India can do translational research. Otherwise, we will be doing basics research and we will be doing clinical research. Both of these will not be able to join together. And that's the biggest thing which I would like to, today we have a problem. Why do I say translational research is very important? Because there is a huge valley of death. Whatever is done in the basic research, 90% of it will fail. The reason is we do not have a good model for actually simulating what would happen in a human. The best systems to study animal models is dog. And we are not allowed to do anything, any research on dog. This is not allowed. And this is why we need to have alternative methods. Of course, I'm also supporting the idea of not using animals very importantly, but there is nothing very close to human which we can actually test out in the lab. And that's where the failure is big. And another problem which happens in these areas is the attrition. Attrition rate is too high in sustaining a good talent in this pool. These two things are going to work against us. Now, what is the major problem if you want to have a very good ecosystem for developing such a translational research? We do academics. Academics, I always say, PhD students cannot be the people to do translation. They need to actually publish papers, they need to actually get. And evaluation of academicians is done on the number of publications which is done. If you are going to have these two criteria, you can never do translational research. It will only be a make-believe situation. So the academicians need to actually interact with clinicians to know what the problems are, and clinicians needs to know what it takes to do academic research in this. Now, there is a need for bridging this between industry. Industry needs to come, and I have heard industry saying, we do not trust an academic institution in this country. And this is from the horse's mouth, I have heard. Industry never comes to the academic because they do not trust the kind of work which is being done in academia. So these are the issues which are existing, and as Dr. Moni had mentioned about funding. So until unless we bridge all these four together, we are not going to have translational research in this country. But this is not bad. There is a need to think about it, and we need to bring out things. Many people have tried, in clinics, clinicians have tried to do translational research, academicians have tried to do translation research, but this has failed because there is no right ecosystem. So what it takes to actually take the translational research forward? We need to have a very improved quality of hypothesis. Most of the hypothesis is based on a limited knowledge, and that limited knowledge is not good enough for us to actually make the right hypothesis. And we need to actually develop it, and that means we need to have a huge number of contributors to this hypothesis. We need to actually develop organized systems, 3D organized systems now. It is possible to take the patient sample cells and try to develop an organoid And using that organoid, we can actually develop model systems for studying what it takes to develop newer products. Deep phenotyping of the patients is very, very important today, as it was pointed out by Dr. Moni. It is different. People are different. The treatment has to be personalized. Precision medicine is on the way, and that needs to be addressing this issue. Drug repurposing is very, very important because many of the drugs fail because they are toxic or various other problems are there in getting clearances. So can we actually try to do drug repurposing? Increasing transparency. This is very important because your data should be available to anybody to scrutinize it. We need to publish the data all over the place so that people can work on the data and tell whether what you did is correct or not. This is exactly what is necessary if we want to go for it. Adopting open innovation and intellectual property is very important. More effective funding mechanism has to be developed. More effective decision-making processes have to be developed. And a teamwork and inter-organizational cooperation. This is very, very important. And India, we need to actually develop this. This is not existing. There is a lot of underlying problems to bring 2 or 3 different institutions to come together to work together. So this is the situation we are existing, and I propose that how do we do a translation research, and this is my final slide. I am actually saying that you have to have the whole ecosystem to be in one place. That means the clinical, the translation, industry and the academia should be in the same place. So we need to actually select a place which has a very robust academic environment with sophisticated instrumentations and everything available, the quality of academicians available. Now we need to actually develop the translational research aspect of it, where we actually need to have a referral hospital. What I mean by referral hospital is, the hospital doesn't compete with all the other hospitals present in the ecosystem. It is a hospital which actually looks at the first line of treatment failure patients. And these are actually supposed to be referred by the hospitals. And they come here, and then you do all the necessary things what I mentioned before in this academic environment. Industries come here, we actually incubate them, we give them the CROs, we give them the CGMP facilities in that same ecosystem. And you also provide an incubation facility for these industries to come here. And once you have such an ecosystem, you actually take the intellectual of the things. Now, one of the things where the failure happens on a referral hospital is that we actually, if you have to listen to the inaugural lecture of Pramesh, he had mentioned that we lack, there is a gap between the nurse and the highly accomplished MD. We need to have an intermediary, people who will take care of the patients, regular patients. Right now, the OP is even done by the MD, who is a super specialty person. We don't want that. We want to have an intermediary. What is lacking in clinicians? One of the problems in Indian clinicians is they lack the basic knowledge of cell biology, microbiology, and biochemistry. These are taught in the first year of MBBS, and after that they forget it. And this is, without this, they cannot actually understand what it takes to do research. And that is why I propose in this academic environment an MS degree, MS by research, a degree for all the MBBS, so that when they do the MD, they already have this actually set up. And this is what I propose, and that if it is followed, I think the translation research in this country would be happening. Thank you.
Thank you, sir, for the valuable comments and challenges, as well as your plan for to solve the problem. Next, may I request Dr. Sabi George to comment on how to integrate, how to actually do clinical trial in a very busy clinician's life. Sabi, this is a challenge we always face in our practice.
Thank you. Thank you, Ampok, for having me, and Dr. Moni for moderating this session. So in the next few minutes, I'd like to talk about the various elements required for clinical trial conduct at your center, and also why it is important. So these are my disclosures. So let me start by telling the story of this patient, Jean. This is name and dates are not real for privacy purposes. Jean was 89 years old in February of 2013 when she failed a standard treatment for advanced kidney cancer. She failed sunitinib and another TKI, and the options that I had for her was everolimus or a clinical trial. So her goal was to live till June of that year when her grandson got married in Virginia. So she asked me, Doc, how can I make this happen? I said, well, I have a clinical trial also. So this trial is testing a new drug called BMS 93658. It didn't have a name, and versus everolimus. So you have a 50-50 chance to get the new drug. And either way, I hope that you will meet your goal. So she goes on the trial, and sure enough, she gets the BMS 93658. She gets randomized to that. And you could see on the left-hand side, the expansilytic lesion of the scapula, which healed over time in 2016. When she came off the trial for toxicity, immune-mediated toxicity, she had a complete response. And so since then, she had been off therapy. And I saw her in September of last year, and I'll be seeing her September of this year. She turned 100, and she's been disease-free and treatment-free for the past 9 years. So that is a profound story, and I do have a lot of those patients. So what did that result in? I had 27 patients on this trial. I enrolled 27 patients on this trial, and I got my name on this paper, which later becomes one of the most important papers in kidney cancer, and this led to the first immune checkpoint inhibitor approval in kidney cancer, nivolumab. So, what are the elements required to conduct a clinical research at your center? So at our center, we do clinical care, clinician scientists do clinical care, research-based practice, and teaching. So every institution has to protect the time, give them protected time to, allow for the physicians to do research. So at my center, say for example, I see patients 2 days a week. The rest is for research, teaching, and travel to meetings and all that. So it varies from place to place, and if everybody is seeing patients 5 or 6 days a week, then it's not possible to do clinical research. And these are the various steps involved in conducting clinical research, being a good clinician, et cetera, et cetera. I won't be going over all of these, but I'm going to highlight a couple of those in the next few slides because of lack of time, and we'll be discussing more, I guess. And it's important to be able to do clinical research. Say, for example, if you want to do a research in clinical trial in lung cancer, you need to see a lot of lung cancer patients. You need to have the volume to be able to accrue to those trials. And that's how you develop expertise. You see hundreds of lung cancer every day or every week, and you know the ins and outs of all that. And so volume is important, and being able to see the things under the microscope. If you see only lung cancer, you see a lot of those, and that's how you develop your expertise and be able to accrue to clinical trials. And so these are some of the steps involved in doing a trial, and you can think and see if all these are possible at your center. So from protocol development to approval by the disease-specific research group or clinical disease team, and then prioritization committee, scientific review committee, and institutional review board, IRB approval of a trial, then contracting and budgeting. You need to have people for all these elements. And then investigator meeting, site initiation visit, and activation of a trial. After the activation, you start the trial enrolling patients. The most important thing is, giving the consent to the patient. Informed consent is a tedious and lengthy process. We have to talk about the options available on a standard of care basis. as well as the research options. And so you have to give the alternatives to clinical trials as well before, enrolling a patient in a trial. And they should not be forced to go on a trial. They should not be enticed to go on a trial. They should go voluntarily. And that's the important aspect. And as a physician, you should be highly ethical in doing this. You should not have a lot of conflict of interest. You should not be promoting the company's drug on one end and then try to put patients on clinical trials by the same company. So these are regulated by the ethics committee and all that. And then study assessments, reporting of AEs and completion, closeout, publication, etc. So those are the elements basically required to conduct a clinical trial and report it. And so it's also important that you have enough clinical research coordinators, regulatory support for submitting the updated AEs and SUSARs, and also investigator brochures, newer version of consents, and being able to consent the patient over and over again with the newer versions. Those are all important aspects, and will take a lot of time and effort and money. And then data collection and data entry in a timely fashion, because those are important when the trial is going to be analyzed. If data are not available from different centers, the trial cannot be completed. So those are the things, and then you report at various meetings and publish in high-impact journals, etc. Now, these are different kinds of trials: investigator-initiated trials, cooperative group trials, and pharma trials. So those are, I won't detail those, but importantly, when it comes to manuscript submission, it is your role. You are selected on a paper based on your contribution. If you haven't contributed enough, you may not be on the paper. So I was blessed enough to have contributed a lot to a lot of those trials, and that's why I have a presence in that field. Now, to summarize again, the important elements of a clinical trial at your center, institutional review board. It is important for making sure that the subject's well-being is upheld and there is enough oversight of the ethics of the investigators and all the people involved. And making sure that everybody involved has adequate research training, including city training, which is the basic training that we require for being able to do research. And then scientific review committees, disease-specific groups, clinical research services. That is a department, a big department with support for budget, regulatory support, coordinator support, data, contracting, etc. And it's also important to have well-trained investigators, as Dr. Chandrabas mentioned. And then these studies are audited and monitored on a regular basis to make sure that they're following the ethical guidelines and making sure that they're upholding the safety of the patients. And DSMB are required for monitoring the studies and biostatical support and writing support for publishing. So that's basically all I have to say. Sorry, I have a lot more to say, but for lack of time, I'll cut short. And thank you. We'll have the panel questions.
Thank you, Sabi. Thank you for outlining the components of clinical trial. Next, we have Dr. Shaji Kumar. He's going to outline about another aspect of clinical research, that is the real-world evidence. Over to you, Dr. Shaji.
Let's see if I can get the slides up. Right. So good morning, everyone, and thank you, Dr. Moni and Aju and Bobin, for the opportunity to be here this morning. So what I'm going to do is to start from where Sabi left off, which is the whole concept of different types of trials, right? So we talked about, see if this thing moves. So these are my disclosures. So when you think about the clinical trial spectrum, right? So we just heard about the interventional trials. I mean, this is something, as Dr. Chandrabas already told you, is hard to do, especially with the resources that we have available around the globe. Clearly, it is the gold standard, and we do interventional clinical trials with two main purposes. One is, can you get a new therapy approved for use in the clinic? And two, maybe not as commonly and definitely less funded, is to ask fundamental clinical questions. How do you manage this patient in front of you? And so those are two very different types of clinical trials, and certainly these are very well designed, a targeted patient population, a very prescribed intervention, expensive to do, but unfortunately the data is not always generalizable to a population that you actually treat. The second set of trials that you can do, which is much less expensive than interventional trials, are pragmatic trials. So these are things that you do day in, day out in your clinic. These are the patients you take care of based on the learnings that you have had so far, maybe synthesized in a much more efficient fashion using AI-based approach, like Dr. Srikanth just talked about earlier this morning. But at the same time, these are very practice-informing trials. The pragmatic trials may not necessarily get you the next drug approved, but it'll definitely tell you how to take care of the patient who shows up with a specific problem. Certainly, these are less objective. And then finally, we have real-world studies, which are essentially using data that exist and not even just prospectively looking at how your interventions or what you do in the clinic is affecting the patient, but rather looking at a past experience of what has happened in the past and what can be learned from it. It's certainly the least expensive of all these different types of trials we can talk about, but again, they have very distinct purposes. One is obviously practice informing. Second is hypothesis generating and use the interventional trials to actually prove that your hypothesis is actually correct. And this can be done fast because these are based on existing data. And this is increasingly being utilized as the electronic health record system is becoming more sophisticated and more all-encompassing and has all the data aggregated in one site. So again, it goes along that spectrum of being objective to more subjective, but they have very clear role to play. So first, let's talk about pragmatic trials, right? So pragmatic trial is really a real-world study, but it's usually looking at the common approaches that we use for treating patients. So a good example is, let's say there's equipoise in the field and there's 3 different approaches that we use for treating a condition. And it's impossible to do a randomized trial, especially as was told about surgical trials, where the equipoise may not be even being there may not be accepted. So can we just do a pragmatic trial? You look at the people who are doing intervention 1, 2, and 3, and see if there are differences in a way that doesn't intrude into your normal practice, but at the same time you're collecting the data real time. And there's a lot of science that goes into the pragmatic trials, and I won't go into all the specificities of the pragmatic trial designs, but again, it's a continuum in terms of that interventional trial to pragmatic trials, and variety of different factors play into the determination how much in that, where in the spectrum you land. So it depends on, again, what is the question being asked, what exact role do the investigators do, what kind of interventions are you prescribing, or are you just watching the interventions that are commonly being used, what kind of follow-up is going to be instituted. And on the other side, you have the real-world data and the real-world evidence, right? So we have real-world data that is basically data that is accumulating on a day, minute-by-minute basis in the patient electronic health records with no extra effort on our part. It is there. The question is, how can we use this to develop or generate evidence that in turn can be used for patients, whether it be changing practice or getting drugs approved. So one of the key things is, again, data source, right? When you're thinking about real-world data, there is a plethora of data sources out there. The most easily accessible one are the electronic health records. So Dr. Moni talked about the 30 different cancer centers in this state taking care of 80,000 new patients with new cancer diagnosis. And that's valuable, that's a treasure trove. The problem is we all have fragmented care, and we don't necessarily communicate in a way that allows us to get this data together. So if you were to, again, not advocating for any uniform healthcare platform, but if all these centers were to put the data together that you're collecting on a day-to-day basis, and increasingly we are all using electronic health records, that, I think, creating registries or just integrating electronic health records gives you very valuable data. and can answer a lot of very, very important questions. Medical claim data is not that easily accessible in this country, but in the US it forms a very important aspect of large data. And registries are something that I would again strongly encourage people to start thinking about and creating them within the context of, again, organizations like Ampok. And of course, there's patient-generated data that patients can also, especially in today's world, everybody has an iPhone or a smartphone in their hand. You can actually collect data directly from the patients using a variety of different apps on a real-time basis, and these can also be an excellent data source. So again, multiple different types of data, not just sources, right? So we have the demographic data, you have the medical intervention data, medical outcomes, genomics increasingly, so we will hear about precision medicine, radiation, radiology data, and so forth. And so again, real-world data designs, we talked about pragmatic trial, we can design prospective observational study when you think an intervention may not necessarily be the right approach for a given situation. And one of the areas that is increasingly getting traction within the regulatory world is the whole concept of real-world controls. We know that it's not always easy for us to randomize patients to two different interventions, which may not necessarily be acceptable. So we have an opportunity to create, 5% of patients in the US go on interventional cancer trials. What can we learn from the other 95% of the patients that can actually help us make those 5% of patients' data much more valuable? So I think a lot more about these externally controlled clinical trials are being developed. And the fact that there are multiple guidelines from both European and American regulators providing guidance as to what are the essential critical elements of that real-world data that you need to generate for it to be actually used for approval of drugs. And some of these are very basic, good quality data principles that we can implement, not just in the context of clinical trials, but also in terms of studies that change our management of the patients. So again, I think even though a lot of the emphasis on the real-world data is currently on regulatory purposes, primarily because that's where the funding is. But we can also use this data to actually teach us on a day-to-day basis about how to treat our patients. And that can be done at a very low cost if we all are able to put our heads together to do that. So I'll stop there and thank you for attention.
Thank you, Dr. Shaji. Next, we have a success story from India, Indian startup ecosystem. May I request Dr. Vidya Veldor to talk about the 4-base case study.
Good morning, everyone, and I thank Dr. Moni sir, Dr. Raju Matthew, and the entire organizing committee for giving us this opportunity to share here. So, yes, it is a startup story, but then it did come with a lot of, hardship in between. We did have lots of ups and downs. So I represent 4-Base Care Precision Health Genomics Laboratory, and this is a young company back in the year 2018. The interest was to, do some precision oncology and genomics and help cancer patients, providing genomic solutions. And it was co-founded by 2 young entrepreneurs. Both of them were masters in biotechnology, and Mr. Hitesh and Kshitij. It was around that time we were lucky. Illumina announced a genomics grant for startups, where our lab was the first Asia-specific lab to be selected by Illumina for the accelerator grant. And we came up with the idea to do a successful industry-academia collaboration. And that was a very, very blessing point, I think, for us, that today if we are able to cross 17,000 genomics panels being sequenced in our lab, it's a lot of effort that has come from both academia and the industry. So, and the concept is, whenever we do research, particularly in clinical setting, we have to ask a question which is more meaningful to the doctor, because the reason for doing translational research is we need to find out what is their challenge. As scientists, can we address their challenge? So bedside to bench and then back to bedside. So what we did was, let us understand all the pathogenic alterations that are known in this part of the world across cancers. And we start sequencing more and more of these genes, then we know who are recurring more. What is the percentage of recurrence? If today we know EGFR is known at 40% in Indian population, it is because we sequenced more. If we know some other gene XY, it is more, then the need is created. And if the gene is targetable, then the drug is being questioned for. So that is how I think research can help in clinics today. So moving forward, this is the kind of what I want to say is the thought process or the hypothesis around building research around the industry atmosphere. So we started with some less than 10 people back in 2018. We are 200 plus today. And we have very eminent advisors from the scientific and as well as industry domain. We have the CEO of Illumina, Francis D'Souza, whose mind and is the brain behind high throughput sequencing, and today we are able to get cost-effective genomics. It is because of his brainchild. And we also have in this audience today, the genome man of India, Mr. Sam Santosh sir. He was the first person who pioneered genomics in India. So, it's a great thing to share our experience here. And this is how we grew from 2021 when we started providing services to the cancer patients. Now I go back in story in terms of what we did in research. So we closely looked at the TCGA data in 2020 and today. We see that the contribution that has come from the Asian population is very, very minimal in 2020. This is the Caucasian data, slightly increased, but predominantly the Asian data has not improved. India contributes 18% of global cancer burden, and Asia contributes 55%, which was discussed earlier. So there is a need for knowing what is there in terms of what types of genes. Genes might be the same because cancer does not change much across geographies, but its response rate and the prevalence of different mutations would change. And I think that's where we need to act upon to help the patients in this part of the world. So this is our first initiative to build a comprehensive panel across all the physicians to help all the oncology community. So we collaborated with Tata Memorial Hospital, Dr. Kumar Prabhash and his group, AIMS, New Delhi, and then Sri Shankara, then Unipoya University, the Yellow Ribbon part of Healthcare Global Group, and of course the entire research was funded by the Illumina. We included 1,500 cancer patients on whole exome sequencing with 32 different cancer types and 435 plus different tumor histologies. We pulled out all the information that has relevance in the tumor biology, onset, driving the disease, and prognostication. And around this, we built a panel, and we call this as the first population-specific cancer gene panel that has been in use last 4 years, and it has given excellent results to many doctors in helping better treatment planning. So before we start, as any other lab, we had a challenge. We went to meet clinicians. They said, you are a startup lab. How can I trust your genetic testing? Dr. Bhavna ma'am is one among them who inspired me. Of course, she said, why should I trust you? You are a good scientist. I know you did well in previous assignments. This is a new lab. This is a new setting. You prove yourself in your lab that you are doing good work. And that's when a clinician can endorse you and say, yes, this lab's results are good and we can take it forward. So our first publication was to publish the extensive validation on 200 plus patient samples for DNA and RNA whole exome in Frontiers in Oncology as per the ISO 15189 and CAP recommendation. And following that, around that time, I must say there were no publications around to support clinical application of whole exome sequencing. And next, we went on to say can we pass on this technology, train more scientists and laboratory technicians to provide afford solutions in rural areas? Along with the Baba Atomic Research Center, BRC Hospital in Muzaffarpur, we established in 2022, and today the lab is up and running independently, providing genetic testing solution, and this is our first collaborative publication. And then it was also helpful in discovery research of red fusions in medullothyroid cancer. And then there is a new story here. It was also told multiple times, just adding on here. TMB, which was earlier put up as the threshold 10, there were studies showing that not all patients from different ethnicities would respond well. We developed an algorithm and we tried to correlate with the Caucasian data, and we found that in Indian cancer, or rather in the Asian population, the TMB thresholds are not the same for all cancers as evidenced in the Caucasian data. And then, of course, when you do translational research, you end up getting novel drug targets, and you can ask many clinical trials. Like, for example, we know 10 different partners for red fusion. We would have identified 3-4 more partners. How do you prove as a scientist to the clinician that, yes, this is also a activating red fusion? If your kinase domain is intact, then you go back and tell your doctor that although the partner is new, the fusion is intact, so it is the driver probably which is driving the disease. So these are the kind of inferences you can draw when you use a broad panel to help doctors. And then last but not the least, what I want to say here is we want to bridge the gap that is there between what is available in the Western world to what is available in India. So we developed a database, and we call this as the Global Cancer Diversity Atlas, which we launched last month, and honored to have Dr. Narayan Murthy, Professor Dr. Narayan Murthy with us, who inaugurated this. And this is the data that has a structured information on the genomics with some amount of clinical data. And this is our team. Thank you for your
Thank you, Dr. Vidya. Thank you. To wrap up the session, I request Dr. Aju Matthew to talk about his vision about...
Yes, hello, can you hear me? Yeah. So I'll just make a simple statement here. I think from a clinician's perspective, practicing in Kerala, there is enough manpower. Our medical oncology professionals are highly talented and skillful. They ask the right question in clinic, they ask the right question for the patient. So manpower is tremendous. The numbers of medical oncologists graduating every year are rising exponentially to a scary level, to the extent that we may think about a Cuban model where some of us may still be jobless. So we have manpower, and I believe we have the funds too. The government is spending money. There are funds available. Research training is available. Tata hosts a Credo workshop, and very few Kerala oncologists apply. And even if they apply, they don't get in because they're not mentored well in the research. So manpower is there, fund is there, research training is there. So what doesn't exist? And that is lack of willpower. Now I'll be true to myself, I just don't have a will to do research here. So lack of willpower is one factor, and lack of incentive. There is no incentive for me to do research in Kerala. So these are two big factors that I see that are detrimental to the progress of clinical trial or collaborative research, for instance. I'll give you an example, practical example. I have attempted to do some collaborative genomic-based research, some collaborative data gathering research, some preliminary rudimentary work, but there is no incentive for anybody to collaborate and give data. Even if you offer authorship, it is, the question is, what do I gain from being an author? So unless there is an incentive and a will, our community will still be copiers and watchers of what is happening across. And this is where I want to may I ask a question to Dr. Vidya? You had research collaborations with these multiple institutions. Why didn't you approach one of us?
So I think it was more of a networking that it came in as a blessing, I would say. Kumar sir has always been very, you know, open to have collaborations, and you know, it just happened that we could meet with Kumar sir, and he connected us with his friends in the board. And of course, we did approach many hospitals. So the good thing that happened here is, unlike in any other collaboration, here every clinician had their own scientific question to ask. And in this kind of a research agreement, we did not want to get into their, you know, so there is freedom and breathing space which we need to give in every collaboration. In the sense that you might have a very important scientific question for a cohort of 200 patients. So that question remains yours and you drive but here is a resource. We got some funding. Okay, let us use it for the benefit of both of us. We have some interesting questions that we want to ask. You also have some interesting questions which you also want to ask. We need not always collaborate with each other and get the same answers. You can have an independent answer. As long as both of us are able to use this information successfully and get something out for the mankind, that should be good enough. And I think the crux was we had enough. Somebody was there to fund us in the beginning. That was one. And even now, today, when we do collaborations, the individual parties have their own questions to ask. And there is no interference. Even though we come from private, that liberty is there. Probably our leaders have been open enough, unlike in any other private firm, that sometimes there is a kind of, you know, what to say, you know, this is the data which should not be in public domain. You know, there can be multiple reasons. Investors might say you cannot put it in public. And another person who is contributing to the data might say, no, you can't put it in public. But for some reason, we have put up an MOU in place where this kind of problems do not arise. So I think that's helping. And even when our collaborators ask some important questions, they eventually involve us to see whether we as scientists sitting in industry can add value to their questions. And I think that's how, and even in the US, I think that works well because there is an openness in the collaboration, probably, in the Western countries.
I wanted to take a strong objection to Dr. Aju. I enjoy the panel very much, but I want to take strong objection when he said that medical oncologists in Kerala are not interested. It's not the question of being not interested. There are a lot of, systematic problems that we face. The first and foremost is that our salary is decided based on the volume of patients that we see. No private institute is going to give me protected time to do research. I have to see patients 6 days a week, morning to evening. Where do I do research? No private institute is going to give me the supporting infrastructure to do research. If I'm going to write a trial, I have to start from the very beginning, from the regulatory framework to writing the trial to get for the budgeting. Everything has to be done personally. The department or the team will not be hired by the institute because they are not revenue-making people. So these kinds of departments can only exist in large governmental or university hospitals. It will never happen in the private sector. So we cannot just see all these and just say that medical oncologists in Kerala are not interested to do research.
So it's a priority of the organization.
Just to clarify, I didn't say that they're not interested.
I was just trying to say.
So same thing, there's no incentive.
The second thing I want to say is that, okay, let us, in spite of all this, we want to do research. We, at MVR, we had a MOU with the Kottakkal Ayurvedishala, and we said that we are going to do a research with them. So immediately the first question came is, how can you do research with Ayurvedic products? You are allopathy doctors, you cannot do research with Ayurvedic products. So when we fashion the trial in such a way, the Ayurveda doctors in Kottakkal will see the patients. In Kottakkal, they'll treat the patients. They'll do the follow-up. The only thing that we at MVI is going to do is, we are going to confirm the pathology for them. We'll bring the slides to us. We'll do the pathology. We'll make sure it is adenocarcinoma. We'll make sure it is EGFR mutated. And two, we'll do the response evaluation. We'll do the CT scans and we'll say whether this patient is progressing or whether this patient is having stable disease. We'll confirm the diagnosis. We'll do the response evaluation. The actual treatment follow-up is done by the Ayurveda doctors in Kottakkal. Our ethics committee refused to take up this trial. They said, no, you cannot, your doctors, you cannot do research or you cannot be part of research because they are scared. They are scared what will happen if tomorrow controversy comes. They don't want to be part of that. So our ethics committee did not give clearance.
Thank you, sir. So Chandramohan, he's from the RCC setting.
Yeah.
Yes.
I think I was standing to here with disagree with some of the panelists. Now, while I was standing, I'm going to disagree with Sridharan also. So why? Because I think when you look at research, the outcome of research should be the improvement of care or contribution to society. Let us take the Harvard example. Harvard is given 1 billion used mainly by federal funding. And they are supposed to give back to society some innovations. And here they're going to give, I think they're giving back some 500 new innovations and 1.6 billion business opportunities. So the money is justified. And why that is not happening in India? Why Shaji Kumar is doing publications in US, not our medical oncologist? Our medical doctors, and not only medical oncologists, even surgeons, we're sitting at busy institutes. I was just talking to John Manikar here. He's saying that in a cardiologist in TRIVANDRUM Medical College is seeing 700 patients a day. How can he do research? At the same time, private person will be saying, I'm seeing only few patients in a day, and I can't do research. So it's contradictory. The reason is we are never trained in research. Rather than reading and by hearting Cunningham, DeVita, we are never bothered about such questions. So it's never in our curriculum. If you have will, I think these issues Sridharan raised are minuscule issues.
These two people are from India.
Minuscule issues, yeah. They are producing large volume and sponsor is US. I think the issue is we have to be really taught about research, and now the good news is that India is changing. Now we have thanks to you, we have a startup thing in Cochin and Yenappa University. There is another startup. They are not only promoting research ideas, accruing funds, making products happen, collaborating with industries and coming with the products. And it's happening. In GCR it's happening. In Cochin it's happening. In Yenappa it's happening. And it's a change. At the same time, you look at US, they are cutting funds. Things are going to be reversed very soon. But I think as a community, we should encourage results. I think Ampok and CAS should concentrate on going to places and make people do publications. Thanks to Aju, publications coming from Cochin also now, reaching good journals. And we should tap on this potential and come forward rather than criticizing ourselves.
Thank you. Next, yeah, please, sir.
Okay. Uniting minds. I think that is what is meant for by this conclave. Or we have to change our mindset. See, my point is that I've worked with the academics. I've worked with the industry. I've been with the funding agencies, Kerala State Council for Science. So all this put me to place few points in front of you. Dr. Chandrabas and Dr. Moni had specifically said about the basic and the funding opportunities that is available. As we know that all the universities or academic institutions, they do basic research. The main reason being that most of those research being done in the academic institutions are PhD programs. The students' aim is to do a good work and then go for publishing. Because if the publication is high impact publication, I'm sure that you will have placement, H-index and all those kinds of calculations are there by which you say that you're a good researcher. Now once you complete your PhD, you do a good work because they involve themselves because they want to have a good research being done. But what happens to that research? The valley of death, which Dr. Chandrabas said. That's one place where all these research findings of the research students are dumped. The reason being that there is no furthering up. There is no funding available. Student gets a fellowship and he does the PhD work, gets a PhD, get good publications, and then...
So the next panelists are lining up there, so we'll just have to
That's okay,
wrap
sir.
up, say,
I need to, because I've been listening to people for the past 2 days, so I think I should say this. The main reason being that you have postdoctoral positions available. Most of the funding agencies, for example, National PDF, they say that you cannot work with the same mentor, same institution. You should choose another place. That means the student will have to refine. As an academician, I'm saying this, has to refine and do an entirely new work when he goes for a postdoc. So means that his work, which was very good, outstanding, because I see most of the differences that is happening, it's not being measured that way to put it into translational research. As is rightly said, there is no funding for translational research. There is no funding even for interdisciplinary research, like what we are telling. There is no, when you do a research work, you cannot take it to the clinical side unless you have clinicians on board. So none of the, I've seen many people running around after the physicians, clinicians, to join a research group. Probably they are scared in the sense that most times they have to part with the clinical samples. They're scared of it. Clinical samples are not available. The clinicians are not on board. So how do you take that into a translational research, bench to bedside? Because a product or a process should go to the society. In Kerala State Council for Science and Technology, one of the best science and technologies in the country, we have now recently introduced a program called as Research Funding, Basic, Interdisciplinary, and Translational. Now, I'm sure that once this fund goes into the students who have done this extraordinary work, it would happen. So maybe that it is necessary the clinicians, maybe that they are in their comfort zones, so they don't want to take any kind of problems like what many people have discussed. But if they can, involved in some research, because they can go deep into the biochemistry, physiology, and all the other details of a cell's function.
Thank you, sir. Thank you, sir.
No, sir, I've just one more, sir, please.
No, I think Dr. Warrior, we want to listen to Dr. Warrior too, sir.
Let me one... Sir,
I can see that's
see,
a very hot topic, and
we have spent a lot of time. See, I have
yes.
one major point. Maybe that this we should discuss. The other thing is that I am in the research advisory committee of Malabar Cancer Center and Regional Cancer Center. I had proposed once because access to clinical samples. Now, all these institutions discard a lot of, surgical discards, which it is mandatory that at least for 5 years they should store it, because on a prior informed consent. What happens to this? Now, if you can have a process called as biobanking, don't you think that you can generate a lot of clinical samples which can be given to the researchers to do the clinical process? That is not happening. I've told both the places that we should have that. Just a classical example is that, there is a private agency called as Sapient Biologicals in Hyderabad. This lady, Dr. Jugnu Jain, came some few years back to have a biobank to be established in Kerala. All these discards, like for example, surgical discards, especially from Regional Cancer Center or other places, many things come in. So can we make them into that? She wanted to have an establishment. She has done wonderfully well in Hyderabad in association with Apollo Hospitals. She wants to have. I took her to RCC, to KIMS, to many other places, but they are not involved in, want to involve in a private company. But then, at least then let there be a public company, public process by which we can have a biobanking here. I'm sure that access to samples, wonderful facility can be created, and probably that we will have the students, I'm sure.
Thank you, sir. Thank you, sir.
Thank you,
Dr.
sir.
Warrior, we have to listen to Dr. Warrior, your comments.
I'm just representing from the management side. Actually, when we started MVR, we were excited about doing research, and we have made all possible. Like we never put pressure on anybody to see that many cases, so that they will be relieved of that pressure and they will be getting a lot of time to do research. But when we see and when we have provided more manpower, what we see is they all leave by 3 o'clock instead of 5 o'clock. They will never, you can't ask them or compel them to do research. And I'll tell you one example of trying to do a workshop on clinical research methodologies. The very few takers for that meeting, that workshop. So I had to apply pressure, and I said everybody should be present. So then I took about 20 odd people out of 80 didn't attend the workshop, and I called personally and I asked them why you didn't come. They said, Sunday I cannot come to the hospital. That was the answer I got. And then about the funding, and also I just want to ask Aju, what do you mean by incentive? Is it the money they want or also about the Sabi. Sabi was telling that only 2 days he sits in OP and see. Suppose we do it, implement here, I'm sure the rest of the days they will never come to the hospital. This is my experience. This is not to generalize any, it's a general statement, but there are few who are really interested. But I am totally confused how to take it from the management side. Thank you.
So I can respond.
One more thing about the funding. I was just talking to Shaji today morning that funding, the government agencies are totally biased. They, the private institutions, they see as they are all looters.
Yeah, that's very unfortunate but true. Regarding the incentives, one thought is give money to your medical oncology faculty or your researchers for every patient they recruit to a trial, or give them some protected time and ask for accountability. You know, incentives can be various ways. It could be credit in terms of manuscript, first authorship, credit to being sent for a conference free of cost to ASCO, anything like that.
I think we should have a separate conclave on research, so on this happy note. Sorry, sir, I think we just have to stop it, otherwise. Yeah. Oh, yeah, Dr. Manu. Oh, yeah, please. Go ahead.
Sorry, sir. One practical challenge we faced is the shortage of manpower in the terms of supportive care, supportive staff. So we don't have trained the CRCs, CRAs people to take us through the regulatory framework. So the courses are offered for this progress, but they are all dissociated from the major academic centers. So we should have trained persons who can work in the ground level. So that is a real problem whenever we started a research that we have faced.
So thank you.
Sir, Dr. Secretary has a statement to say.
Thank you, and now I request Dr. Arun Philip and Dr. Lakshmi Haridas to please come forward and hand over the memento to our moderator and the panelists.
Ampok, in its small ways, has decided to do some research activities. The first and foremost of the activity was the cancer survey project which we released yesterday. That is a very small initiative. We can continue with that. Don't waste it. So that's a small initiative which we have taken from the part of our association. We contributed from the association's research fund. So through that thing, we were able to achieve. We were able to come out with a good manuscript that got published. I know it's a very small data, but then that's all. We all need to take those small steps. I'm happy to announce here that as part of the Cancer Conclave program, we are introducing a research grant for which an amount between 5 to 10 lakhs will be granted to for genuine research. So many of our international faculties have agreed to be independent reviewers. Dr. Shaji, Dr. Sabi, Dr. Hari Parameswaran, to name the few. So they will sit at a committee, but it will not be for an individual. We want to encourage teamwork. So we need doctors from different centers to collaborate to come out with a project, and then when that project needs to be submitted, that will be scrutinized, and the best project will be awarded the amount that has been discussed. So that will be a neutral platform. It will not be an individual based. It will be an institutional base, so to encourage teamwork. So that's a small initiative that Ampok is starting as part of this conclave, and by our 2.0, Kerala Cancer Conclave 2.0, that will happen in 2027 December, I'm sure that we will come out with good papers from our side. Small initiative, but definitely we are there. So for that thing, we need the support of people like Shaji sir, Sabi sir, and other people from abroad also.
Thank you all.
Good morning to all. We go on to the next session, which is cancer genomics and precision medicine in cancer care, unraveling its full potential, especially with a focus on Kerala. This session will focus on the impact it has had in our clinical care and also how we can impactfully deliver it in our current society. I would like to welcome our moderator for the session, Dr. Sevanthi Limaye, whom we know as a leading precision oncologist at HN Reliance Center. Madam is also the in charge of the translational oncology research over there. She has more than 2+ decades of clinical experience in oncology. She has written, Dana-Farber, Columbia University, a lot of experience there, and then has come back to our country and is working there at the moment. I would also like to welcome my panelists. We have esteemed set of panelists. I would like to start with Dr. Ramesh Hariharan, who is also the CEO and founder of Strand Life Sciences. Sir, please come ahead. We have, he is also an adjunct professor in the IIT, Indian Institute of Sciences. Dr. Sam Santosh is a major entrepreneur, a major player and founder of MedGenome. I think a lot of us in this sitting here have seen the impact of his work. Sir, please come ahead. MedGenome, AgriGenome, a lot of companies are there. I would also like to involve Dr. Amol Akhade, who has had a lot of impact in teaching our medical oncologists a lot of data. He is a community oncologist with more than 2+ decades experience. Please take a seat. In Suyok Cancer Center in Mumbai, where he is the lead. I would also like to welcome Dr. Suruchi Agarwal. She is somebody we have interacted with in the past. She is right now serving as the Associate Director of Strand Life Sciences. She is a genomist. Also, she has genetic counseling, PhD also in genetic counseling, a very impactful area. And I would like to welcome Dr. Prashant Ganeshan, sir, Professor, Jipper Medical Oncology. He has more than 2 years plus experience, 2 decades plus experience in oncology, and he has also been in institutes throughout his career and will give a perspective from that. Without much ado, ma'am, I'll hand over the session to you.
Thank you so much, Dr. Nikhil, for all the hard work and the coordination to bring us all here together. And huge thank you to the Kerala Cancer Conclave organizers and dear friend Aju for inviting me to moderate this session. It's a true honor and privilege to be standing here today to moderate this session. And amazing session, the last one. We saw the banter at the end and great moderation to follow in footsteps of Kuriakos sir. That was amazing. Now we have 2 of us, myself and Amol, have to catch the 1:35 flight. So we have a hard stop at 12 o'clock and we are going to go rapid fire with all the questions that we have collected. So first of all, a very warm welcome to all panelists. It's a great opportunity and privilege for me to have you here sitting as my panel to help go through some interesting topics and questions, some of them very, very controversial. Considering I'm standing here, a lot of the people in the crowd may be able to make sense of what I'm saying, and Amol will certainly understand what I'm saying. So, we talk what's standard of care, we talk beyond standard of care, we talk what's game, what's not game, and we deliberate on the hot topic, genomics and precision medicine in cancer care. Okay, so I say the view from India because, a lot has been said about precision medicine abroad. It is, I was just going through opinion pieces that have been published in the recent times from Indian authors regarding precision medicine, precision oncology, and essentially everywhere it said, India is yet to arrive in precision oncology. So with that, I would like to open our panel discussion to see how we take this forward and what is our view from India. And of course, we are graced by none other than Dr. Suresh Advani sir here, who is godfather of oncology and truly would be able to, I would like to get your insights as well, sir, when we deliberate as to what has become of precision medicine and what is going to happen in India. So I put up 3 faces here: Vivek Subbiah, Ben Westphalen, Razel Kurzrock. 3 giants in precision oncology globally. And then we have our panelists. And what do these guys say? Vivek Subbiah says, tumor agnostic all the way. Ben Westphalen says, let's all MTB. And Razel Ray Kurzrock says, precision will be the cure that cancer needs one day. Opening to my panel here, and we have called them speakers, so please feel free to take it on. What's your thought of that bullet mark? Where do you think we are in precision today? And we can start from that side, from the clinician's perspective, Dr. Prashant Ganeshan. Could we help with a mic?
Yeah, it's a very broad question, so do you want any specific thing? Where do we...
In general, what do you have in terms of feeling? Do you think there's a lot of work left?
Obviously, in anything, I mean, that's a very general question in oncology, right? Obviously, there's a lot to do. There is a lot to do.
There's a lot to do. Do you think we have arrived anywhere?
So that's very country specific. So it's like asking, in oncology itself, have we arrived somewhere? Of course we have. It's not like we have not achieved anything. It depends on what you compare yourself with. So in oncology in general, we have made huge strides in access, because I would say 10 years back, the amount of people getting access to oncology care was very limited. Now it's much more broad. But are we getting access to all the cutting edge things which are going on? Obviously not. Is our research up to the mark of what is there in the world? Probably not, but again, we have come huge ways. We are producing very high quality research from this country. Maybe baby steps at this point of time, but definitely moving in the right direction. So the same thing applies to precision oncology also. There are now good labs providing high quality reports for us. And there are many labs which are coming up. So the access is increased. So whether the quality is the same of all the labs, that has to improve over a period of time. Just like we talk about pharmaceuticals, the same thing applies to genomic data, genomic labs also. So we are improving from what we were a few years back, but I think we have a long way to go.
Great. This is exactly what I was looking for, that there is hope. As we discuss precision here, it's not all dismal. We are following through. We are coming in line. There is hope. We are working towards a perfection. But hey, I think precision world itself is evolving globally, and we are also chugging along. So when we say precision, we talk about NGS. We talk about other biomarkers, new age biomarkers. There is a global endorsement. There is beginning to happen tumor agnostic approach. There's also molecular tumor board, which is being considered to be pivotal. And of course, the need for equitable and evidence-based implementation. So from this side, Dr. Suruchi Agarwal. Suruchi, we have interacted together for a while, and I appreciate your contribution as a molecular scientist. When you are abreast with patients today, when you are in the open where people are interacting with you for tests, have you seen the pendulum move? Have you seen some changes happen over the years that you've been out there talking to people, interacting, and helping guide people regarding precision medicine? Do you think people are more aware, or are we still very far behind?
So in terms of when I talk to the patients, definitely awareness is still lacking. We have to have much more awareness programs for the patient to make them understand what genetics is and how genomics can help actually in their treatment. However, the counselings and, it has to be like a triangle. It has to be like a clinician, genetic counselor, and a geneticist and a lab, and also a pathologist. So that triangle has to be completed, in order to bridge that gap, what we see today. So I feel that we are still scratching the surface in terms of genetic testing and in terms of awareness and all. So bridging the gap between clinics and the lab and the counselors would be the way forward.
Great. So I think we are all struggling with the gap. We are all realizing, accepting that there is a huge gap, and we are all, I guess, working towards bridging that gap. As people involved with precision medicine, we are making active strides to try and bridge that gap.
Molecular tumor boards would be one way, but that is also, I feel that that discussion is, is done in silo and is kind of closed discussion, very much closed discussion. So I feel if it comes out in form of some kind of a database, in form of some kind of case series or those kind of things,
Yes.
I think that would be really helpful for the mass to understand what are we doing with the patients using this information.
Great. Thank you. Amol, my question to you as a clinician now. So, there's a picture here, diagnostics and treatment, and it's a perfect match. And then, of course, there's this picture, which just by looking is very intimidating, because you know that there are so many possibilities in each malignancy. But the patient in front of you may or may not be able to do it, may or may not be able to understand the importance of doing it. How do you deal with that challenge?
So I just wanted to have a summary of the 3-4 slides that you have shown before, starting with the concept of that the tissue-based origin or the organ-based origin should be out. And there was a paper in Nature a year back saying that the way forward should be based upon the molecular markers rather than organ of origin. Now, we have not completely reached there because exactly what is shown in this particular slide, because not every particular mutation will be a driver mutation in a particular tumor type. For example, HER2 will be a driver mutation in breast cancer, but may not be that strong driver in the colon cancer or a stomach cancer. So just by mere presence of mutation is not going to have desired results, in fact, equal desired results in all tumor types. Hence, what you have said in the previous slide, that the diagnostics and the treatment matching, that need not be a perfect matching every time, and that is where the role of molecular tumor boards, that is where the role of the oncologist comes into picture. So even though we feel that it is a precision, but that precision is not necessarily precise in everything. For example, if you take NTRK fusions and the anti-NTRK drugs, they were perfectly fine. But that kind of perfect matching is not seen necessarily in all the mutations and the drugs and the tumor types. So we are still not yet reached to a matching thing. We are still not yet reached at the exact precision. And that is where the molecular tumor boards, that is where the experience of the treating oncologist, all those things come into picture.
Wonderful. Very well said. I think precision itself is not very precise yet. It's a developing science. It is, even though I am a die-hard precision oncologist, I accept this completely, that we haven't really figured out a whole lot yet. Having said that, you see this entourage of drugs that have developed that are all biomarker based. And so I would say it is truly a happy time for medical oncologists as well as for precision oncologists, because you have so many biomarkers to look out for. It is actually intimidating sometimes. You know, you feel you may miss out on something, you may not catch up with the data, you may not be aware what needs to be done, you may not be able to give, and there are so many times even after we find the biomarker, we are not able to give the right drug. I was just, in preparing for this moderation, I was just catching up on how many approvals have happened. Some of them I may have misspelled because I was just trying to get the names from someone's video. And this is not even the last 3 months. Even the last 3 months have seen many more drug approvals, like N-HER2 for HER2 low and ultra low has just happened in the last 3 months. So a lot of DAY-2 just got approved for FDA approval, just came through. And so many, many such drugs. It's actually truly a happy time in terms of if you had the playground, you could play around with so many biomarkers and so many drugs. But if you are left with some limitations or large limitations, this is a frustrating time. So that's why now the questions come to two entrepreneurs here. And my question, and I'll ask Ramesh first and then Mr. Santosh. My question here is, as we are going ahead with such elaborate biomarker discovery, how as a leading lab do you stay up to speed with what's going on, and how much do you want to catch up, and how do you deal with the money angle of the need? So I'm asking too many questions in one.
No, that's a good question. So in the last decade, India and labs like us, the environment, the ecosystem of labs in India have sort of done a reasonable job in keeping pace. But I feel that's going to be under threat in the future, and I'll tell you why. When we started, almost a decade back when we started genetic testing in India, you know, EGFR was still happening, single gene tests were happening. But within 2, 3, 4 years of that, panels were there, and then the progression was very rapid right thereafter. And we were able to do that because most of the markers that we're talking about, everything on this slide, were largely single gene. Even though you're doing a panel of 20 genes, 30 genes, 70 genes, 100 genes, whatever, your actions are based on single genes. And single gene measurements are eminently, you know, easier to make, easier to infer, and all of that. So that catch-up has been relatively fast, even though there have been lots of technical challenges, right? Our turnaround times can be lower than Western labs because we need to batch samples, while Western labs have more volumes, they can do it faster and all of that. All of that has changed over time. You know, turnaround times have come down. The set of panels that we're offering have improved. So it's been slow, steady, reasonably, not too slow, but reasonably steady progress over the last several years. Now, going into the future, which is where I worry, the nature of the biomarker is changing. It's not going to be the single gene biomarker, and oncologists are used to it. If you remember Oncotype DX, that was our earliest sort of precision test, right? Before this wave of things came about. That was not a single gene. That had 21 genes and some complex function of that, and you couldn't trust anybody else to do it because that function only Genomic Health knew. Now we are at the cusp of a wave where the biomarkers are going to become multi-gene again. And when things become multi-gene, you have to run clinical studies to establish the, within quotes, the AI nature of, you know, what is the combination of those multiple genes that will give an output. And then only the people who have run these large clinical studies, you'll be able to trust only their output. I think we are on the cusp of that going forward. So I think we will have to change our habits, put on different hats, and look at it in the future. I think we've done a reasonable job in the past, but the future is going to hold more challenges there.
Great thoughts. We heard molecular tumor board, we heard tumor agnostic, we heard we are catching up clinically in terms of the tests that we are offering our patients. And we heard how we need to evolve from just a single gene. And going back to what Amol said, sometimes even that single gene does not behave the way we expect it to behave in a different context. So context may be important, and context, by saying context, we need to also understand what are the other accompanying genes, like even EGFR. Earlier, when we had the FLORA trial, we had only osimertinib for EGFR exon 19 and 21. And now with FLORA-2, you're supposed to understand what other genes are there along with the EGFR exon 19 and 21. And if there are all these other bad behaving genes, you know, if the EGFR is in bad company, you've got to add more medicines to the drug. So with that, and with the one cue here of the hydras and that cancer is an ever-evolving disease, I come to Mr. Sam Santosh. Thank you for being here today on our panel. My question to you is, you have been there, done that. You've been the founder of MedGenome. You have also been an incubator for many companies. You have mentored the development of genomics and been a pioneer in India. My question to you is, as you see the horizon changing, and in the brief conversation outside, what I heard was, there is hope. My brief conversation with you, and that itself was great. But when I see this slide, and in clinical practice also, this slide is not to scare anyone. It is a reality that we face every day in our clinic. How does one wrap our head around a disease which is ever evolving, and where genomics may just be a small piece of the puzzle, and there may be time now to move ahead into multi-omics, and you may have already moved ahead as a mentor, and I would like to understand that angle from you.
Sure. As the earlier speakers said, I mean, the first wave was looking at when we moved from the standard forms of treatment and went into more personalized or precise approaches in treating cancer. The first wave, what Ramesh was also saying, was trying to find the key genes, right? Key genes, and trying to see what are the targeted drug available for that. And that had a great success. I mean, that is why the first wave of targeted medicine was success. But as you pointed out in the slide, cancer is a much more vicious disease and it keeps evolving. So there are a number of ways that things that are happening, fortunately, in what is going to be the future of cancer treatment. So one area that I've been working aggressively is in multi-specific antibodies. So the first wave of antibodies that have been a dramatic weapon in treating cancer still has some limitations. You know, if you go, how many people are with HER2? How many people are with EGFR? You know, and also the challenge of identifying, studying the biology, the earlier slide that you showed. What are these gene mutations doing? So understanding all that, and how does it change from person to person? And then what is the microbiome doing? We know the microbiome is a very important factor in precision medicine, and for the person to respond to the treatment. But in one way, the multi-specific antibodies are going to be a very significant weapon because the additional mutations that we find need not be the driver mutations. So let us say a patient has 3 or 4 other mutations which are not normal. I mean, it is somewhat related to the cancer, but it may not be driving. But if they are more there in the cancer cells, right, you can use that target as just a guiding one, right? So Because most of the challenge with the antibodies or any drugs are the toxicity. I mean, you may be able to kill the cancer, but you kill other cells. So if there is a second arm or a third arm to the antibody, I mean, you all know the antibody, the Y-shaped antibody, so you can put many arms around the center. So if you put additional arms and use them in this way, so multiple ways. One is to be a beacon, and so hit the cancer cells alone. Second thing will be to add maybe one target is not enough to make it efficacious enough. So you can have the second one to make the treatment more efficacious. So I see a lot of new drugs coming in the next maybe 5-10 years. Unfortunately, many of them will be from China, made in China, then manufactured in the West. So we may be left out unless we get our act together. And the challenge will be in also having the data. So doing as much sequencing as possible of all the samples that you get and keeping all the data and the samples also safe, so that we will have enough data to know like what are the mutations that are more prevalent in parts of India, because there's going to be, even when I was running MedGenome, we could see the mutations vary significantly across geography. We don't even know why. And even like side of a river, you can see some mutations being much more. So there's a lot of things affecting that. We may not be able to solve all that, but at least with the data, and even if we don't know the fundamental biology, we may be able to make use of that and solve it.
Amazing. So I echo that from my trip to ASCO just a few weeks back, where I felt that the large presence of drug development was actually from China, and we weren't there. You know, I was just regurgitating my clinic data. I was asked to give a presentation, and all I could do was contribute
Ma'am,
to...
sorry to interrupt in between. A humble request from our side. Everyone who's having the tea, kindly keep your voices low so that the session is not disturbed. Please, everyone, keep your voices low so that the ongoing session is not disturbed. Thank you.
Thank you. Actually, we are quite loud, so I think we are fine. So, yeah, I was just saying that in ASCO, it was completely clear that we weren't there and they were there. So taking a leaf from that and bringing us to, I think I've said it enough that there is, requirement to proceed further from single gene focus into multi-omics, and done a lot of work as a clinician in this area. I'm a big fan of iPredict trial and a local trial that I was involved in, a resilient trial. And multi-omics does give different results, and I actually am currently treating a patient where we had PD-L1, PD-L2 amplification, and this patient did not respond initially to immunotherapy, but to multi-omics treatment. This is a young patient. 3 years ago, the patient was advised best supportive care by an academic center, and with chemo sensitivity, drug sensitivity profiling, and genomics and multi-omics, we've been able to now have a near complete remission for this patient. He was on truckloads of medications for pain control, and the pain is no longer there. He's off of all medicines except for the combination of therapy. This case was also guided by the WIN consortium. So I've taken this case to multiple different molecular tumor boards, and in one such molecular tumor board, then there was guidance given, and I changed the, so I run many molecular tumor boards almost every other day. It's a huddle. I call it a huddle. We do a working meeting. It's not essentially a formalized molecular tumor board. We do with individual companies. We do one with Strand as well. With Datar, I do with WIN consortium. I do molecular tumor boards. We have run a previous molecular tumor board initiative called Impact India International. I've run the Sloan Kettering molecular tumor boards. I've also run the another local molecular tumor board. And so what I'm trying to say is what Amol just said, I truly stand by that. I think unless and until we sit down and deliberate, the cases are so complicated, the tests are difficult to understand. Unless we bring people together, it will be very difficult. Now, from one sentence that is here, so these slides are actually from Aju. Aju had laid out 4 points for what we should be addressing today. And in that, I have one of the points picked up regarding the current momentum, which includes cost, which includes different types of material that we test, tissue versus liquid, which also includes AI-powered insights, and something that is not here, which I believe in a lot, is functional analysis and drug sensitivity. So this is going to be deliberated now as we go ahead. Cost of precision worldwide, and what do people say? So one message from here, what is the cost of not testing? I would like all of us to think about that. Give it a moment. What type of cost do we incur if we don't test in specific conditions where we must be testing? That is what we need to focus on, because enough has been said about whether we test, how can we test, how do we test, etc., etc. So coming to the two clinicians in the room, I would like to pick your brain on this. You know, there are times when even if the patient can test, you have to sit down and really work with them to understand why should they test, because they went somewhere else, multiple places, and nobody really recommended to test. Have you had such instances?
So I work in a highly resource-constrained setting. I work in a government setup. So we do not have a lot of in-house molecular testing. We just do basic panels for lung cancer at this point of time. So if I have to test, I have to send the samples outside. Most of my patients cannot afford it. We have to arrange funding. So the first thing we have to ask the question is, if I find a mutation, is my patient going to afford that therapy for it? If they cannot afford, then I don't test, because there's no point in testing. So I think from my context, the question is very moot, because most of the time the testing is directed by the patient whether they can afford the targeted therapy or not. They cannot, then there's no point going for a huge panel or something like that. So most of the time we go for, if that's going to be a specific question for this drug, I just choose that particular mutation, the cheapest, and then I test only for that. So I don't think I really come across a situation where I want to do a lot of testing and somebody else is, it's probably the other way around. They come to us and say that we've been advised this whole bunch of things and I cannot afford all this, what can I do? And I say that, yeah, you can use all these other options without all these testing and very complex things. So I think we work in a completely different thing. So I know this is a discussion.
So I'll tell you, the insight is very important. Situations in India are very diverse. We absolutely need to understand. Just by presenting the topic, it does not mean that we'll make it happen. You know, no matter where I stand, on this side or that side of precision, doesn't matter. This conversation is regarding being able to make it happen. And so it's very important to understand how the world is operating. And you have brought to light the restrictions, the limitations that are very, very paramount. That's the elephant in the room. No matter how much we deliberate, if we know that we cannot perform the testing, we have to first enable that. So then I would like to ask the next question to you, which will actually help us understand a little more. If that patient comes to you and someone has told him, do the testing, and he doesn't have the money, which door do you knock on? Where do you go? What is a resource that we should all be aware of?
So there are various, currently it's very difficult to get funding for testing from various government schemes. So many of the patients are able to access cancer care because now we have, most of the state governments have insurance funding. The national ABPMJY funding is there. But they do not very actively support testing. Testing is expensive. So that's a limitation. So what we do is some tests we think is very essential, it's going to really impact management. That happens for most of the leukemias sometimes. So we tap into, we have our own group of social support people, some local NGOs. We have a WhatsApp group, and we just put into that group that this particular patient needs a test and it's going to cost 10,000 or 15,000, and then we have a lot of people who put in the money, and then we are able to do that test for that person. So that's one way we do it. There are drug companies, based on their products, they subsidize some of the tests. So we make use of that to help them to access that. Sometimes we do that for PARP inhibitors. So for the BRCA testing, we make use of those subsidized coupons. So that's another resource that we tap into. There is something called a Prime Minister National Relief Fund, which I think some of the hospitals can tap into. It's not probably easily accessible for many of the hospitals. So we are government centers, we can tap into that. So that we can use for testing also. So that's a little bit more liberal actually.
But the reality is that that fund may actually become available much later, because it's not available until the patient has a diagnosis. So you have to pre-plan. Yeah.
So you have to pre-plan. The patient comes, you assume that this patient is going to need this down the line. So you start applying for that, assuming that you will do the test 2 months down the line, but you start something else at this point of time. So we pre-plan that, yeah.
Yeah, great. Thank you for the insights. Amol.
So I happen to work on both sides of the system, the government as well as the private, including the corporate section. So I agree with Dr. Ganesh about, Prashant, about what he said about the government sector. So I will try to tell about the other side of the story, that you asked if the patient comes to you with a bunch of tests, what advice I give. So there are very clear-cut guidelines by ASCO as well as ESMO that which are the situations in which we should ask for this test and which are the situations probably these tests are not that useful. And there is a scoring system given by the ESMO. So I apply that, and if the test is required, as per the current evidence, it should be done. And if we explain that to the patient, they of course do it. So our job is to have this balance of use versus abuse, and probably because everything that is available unfortunately gets abused also. So a lot of abuse of precision oncology happens. So as a job of the oncologist is to keep a balance, and there are guidelines clear-cut available, and we have to use them as well as we have to see the situation of the individual patient. Suppose he has received multiple lines of therapies, he has come to a refractory situation, of course he should be offered genomic testing so as to find out some way forward. So we have, again I will repeat that the precision, if used blindly, can have paradoxical results, and hence it is the person, the oncologist who is using that weapon is the most important person. He has to use it wisely. Otherwise, it will have paradoxical results.
Thank you. Thank you. Very well said. I think both clinicians are overlapping in some of the thoughts where there is struggle, there is difficulty utilizing, and then there is
the cost part,
opportunity.
the point you said,
Yeah.
the cost is gradually coming down.
Yeah.
And I'm happy that so many companies are getting into it. And something I always tell, now Reliance also is getting into making this. And I tell people, look at the internet and look at the SIM card. The moment Reliance is into it, the cost has gone down. So please make sure that the cost of the genomic testing also is going to go down. In the next 4 or 5 years, Mukesh Bhai will get all the costs down. So it is good for everybody.
We're going to take this message back.
Yes, please.
Okay. So thank you. Thank you, and thank you for that challenge. We'll have to, stand up to that. So now on the other side of the pendulum, I have a liquid biopsy tracker with Signatera, and you can see there are 3 tests performed for this patient. The patient was offered immunotherapy for stage 3 colorectal cancer. Patient had had a previous treatment with Folfox 10 years ago, was left with severe Neuropathy, we could not offer, refused, the patient refused to take any further chemo. The patient is Lynch syndrome and MSI high, and this patient then was offered immunotherapy. You may be aware of the atomic data that has just come in with immunotherapy and chemotherapy. This patient, however, refused chemo, was just given immunotherapy, had multiple lymph nodes. Now, liquid biopsy tracker was used to see how his ctDNA load was coming down and that he was responding. So, question to Ramesh and then to Suruchi. So, basically, Ramesh, different types of genomic analysis are today available in regular clinical use, tissue and liquid. Liquid biopsies have now really forayed and become wider in their application, and you are leading one such effort. From early diagnosis to response tracking to treatment escalation to de-escalation, it is informing genomic field in a very wide way. As someone who has led this endeavor in India right from the start, what do you feel regarding the liquid biopsy role, both in early diagnosis as well as in response tracking?
So clearly this is the next, among the several next waves, I think this is clearly the next thing that we have to pay attention to. And we have a very core technical challenge there. I mean, the technical challenge is not often discussed, so I'll put it out. It's you take one tube of blood from a patient, hoping to get insights into either they're a normal person you're screening and you're saying, do they have cancer? Or they're a cancer patient, they've gone through surgery, you want to check whether there's some remaining traces of the tumor still remaining, will the patient be at a high risk for recurrence? So you take one tube, two tubes, let's say, so you get maybe 20 nanograms of DNA. That's all, many people you might only get 10 nanograms, some you might get 30. Those 20 nanograms of DNA will have about 6,000 genome equivalent, 6,000 DNA molecules in there, right? And now tumor presence either at an early detection stage or post-surgery stage is not going to be, it's going to be well less than 1 in 1,000. Maybe it's going to be 1 in 10,000. But you have only 6,000 molecules of DNA in your tube, and you're trying to detect 1 in 10,000. How do you do that, right? So the standard liquid biopsies that are used for treatment selection, where you have a patient, it's clearly a patient, typically the tumor presence in the blood is much higher, it's 1 in 1,000, and that's what we use for treatment selection. Those liquid biopsies will fail in the early detection and MRD settings because you have to go down to 1 in 10,000 and you have only 6,000-7,000 molecules to work with. And there, the solution lies in going broad, that any one place in the genome, if you try to track, because there are only 6,000, the relevant mutation may just not be there. But if you go broad, track lots and lots of places in the genome, or go very personalized, identify that this person had the following mutations in their tumor and track those. So that becomes tumor informed, where you have to do their biopsy or a surgery sample first, pick up the right mutations, create a special panel with those and track those. So it's going to lead to a situation where either we have to go very broad or we have to get very, very personalized, meaning for every person create a different panel. So I think the next wave is clearly early detection and minimal residual disease. That will give us a great deal more information into every patient. But we have these technical challenges, and the way these are being solved is looking for biomarkers that are very, very broad, right? So what is a biomarker that's very broad? Mutations are very specific. Methylation signatures are very broad. Thousands of regions across the genome will get affected. So you're able to detect 1 in 10,000 with that. Or by creating, like you showed Signatera, right? What they do is sequence your tumor. Tumor may have thousands of mutations, not necessarily in the genes, could be anywhere, doesn't matter. Now you pick like 16 or 20 or 30 and create a special panel and go very deep, 100,000 X measurement, which is very expensive to do, but you do that. So I think we have to fundamentally change the way we think about liquid biopsies to be prepared for this next wave. And we have to be aware of the fact that the same liquid biopsy that we do for treatment selection is not what's going to work for these. And we've got to get the costs of these things down, because these are again going to start at a high cost, like we did with our regular liquid biopsies and solid tumor tests a decade back. And over the next several years, we have to continue to bring them down. So it's going to be one more wave of going up and coming down that we'll see. But clearly, there's going to be a lot of knowledge gained from these, and hopefully it will help. Right?
So, from Prashant to yourself, India and the diversity, so clear, right? Limitation to perform the basic, and then ability to deliver at international level. I think this is what is India. This is how we deal with the diversity. These are the challenges, and I actually feel quite intimidated when I'm faced with, so I work fine in my own cocoon as a private practitioner, but when I come out and I listen to the stories, it is a true challenge, and you all are true heroes, because that's what you're serving. My question now to Mr. Santosh. So you heard the diversity, you heard the challenge. I have a minute and a half. I think we'll go a little bit over time. Yeah, thank you. As someone who has really led this right from the beginning, the evolution that you're seeing right now, and the realization that a lot of the genomic efforts are actually struggling. There is this cost challenge. Tests are so expensive, patients are unable to pay. There's a very bizarre horizon that is happening out there. There are tests coming, there's some undercuts happening to clinicians, there is, tests getting bought, sold. You're in that commercial market. And then there is this need of really bringing the cost down. Do you think it will happen? Will the technology allow that?
Costs will come down, but at the same time, just like what Ramesh was saying, the other challenges are there, right, as we unravel the onion. So the sequencing costs come down, but you have to go more deeper now. So that means, what does that mean? That means you have to sequence more, right? More. So that will bring the costs up. And there is a limit also to how much the sequencing cost per se can come down, right? There's some fundamental basic costs of sample collection, extraction, library preparation. So, so it's very, very difficult to go much down. So not only in testing, in the whole healthcare thing, the costs are going to go tremendously up. There is very little we can do about that.
Do you think there'll ever be a geo for NGS?
No.
No? Vivek Subbiya was once speaking in one of my meetings, and he said 100 rupees.
No.
I'm speaking at an Indian forum, and 100 rupees.
People confuse what you can do in telecommunications or in computers in healthcare. You can't do that.
Coming to you.
So, yeah, maybe you should.
Vivek was close to his prediction. He just said 100 rupees, it should be $100. It will come to $100 for sure.
$100 for sure.
$100 also it would be a great thing.
$10,000.
Yeah.
So it will come down to $10,000 eventually.
Yeah, very true.
Yes.
Can I just put a
I see some activity happening now. Yes.
No, it's very, very good that the costs keep coming down. That's why we are able to do some of the tests which we could not even think of 5 years back. So it's good. But at the same time, the mushrooming of genomic companies which are available now out there. So just like in the pharma market, there are so many companies manufacturing. How do we ensure the quality? Is there an effort, at least,
That's
there
a brilliant
are
point
accreditation
put
and all those
forward.
things. But
how do you know?
How do I know that this test is reliable?
So that is the whole point that we discussed yesterday also about the pharma companies, that there has to be a governing body which will tell the clinicians and the patients that there is a gradation available and we have evaluated this company, and it is a grade A plus company or B or C, whatever grade, so that it becomes easier, because there are too many of them,
But accreditation and validation data actually is important to understand. So when
But
we go
Suruchi,
and
we don't understand, right?
No,
Half of the
when-
clinicians,
No,
we
it's-
just don't understand
the
what data you are presenting.
The accreditation is for the lab, but what about the individual tests?
No, it is for individual
Test can be accredited
tests.
too.
There
Each
are-
test has to be accredited, like CAP
Exactly.
accreditation.
Each test is accredited, and there are biannual proficiency testing. Blinded samples are sent to us, and we do blinded tests, and we do ensure that the quality standards are maintained. In addition to that, we have internal audits also going on. So if we have to maintain that accreditation status, the internal audits has to be done periodically and the data shown. Monthly QAD meetings. we
You
have
are
a-
doing it. I'm not asking about
no, I mean,
Strand or Medgenome, but I'm talking about the 20 other companies which are all
Correct.
coming up with these
Yeah,
products.
so
People like us, we just remain in that 4-company cocoon. We don't want to move out because you never know what
So
the
there
others
are-
are doing.
You have a website or a site where a clinician or a patient can go, and if I click it, I can see these are the 20 companies accredited and approved.
Yeah, so that is so that kind of data, or for each test, your percent positive agreement or negative positive agreement, specificity, sensitivity. So this
The government has to do that. It's the
be
government.
kind of open by the companies.
So, Suruchi, since you have the mic, MTB. I have 3 papers out here from folks in India who have written about MTBs, and there was there is a meta-analysis that has also been, so there is a lot of buzz around MTBs happening. But, I was the other day asking the Tempus guys, actually really, I was being stubborn with them and saying, if I'm ordering you test, why don't you have an MTB, right? And they couldn't make it happen for me. So I'm just saying that even in the West, and when I led the MSKCC MTB, I realized there was dearth of molecular scientists sitting on that board. When I would run the molecular tumor board, we didn't have assigned people, the clinicians were not talking to the molecular scientists, and the clinicians knew what they were dealing with. But we had all kinds of cases, and we had surprises there, and it was so tough. So, question to you, as a person on this side, opposite of the clinician, do you get requests for MTB? How common are those? Are you able to facilitate them, or there is a void?
Yeah, so I think you are reading my mind. So this has been going on my mind from last maybe 1.5 years since I'm interacting with the clinicians. So basically this is the biggest gap which we see. And as you rightly said, there is a dearth of molecular scientists, and there is a dearth of representation of molecular scientists on molecular tumor boards. So what I feel is, sitting on the other side, is that when we talk about molecular tumor boards, they are hospital molecular tumor boards. And we molecular scientists are often associated with certain companies, with certain labs, who are having some strategic collaboration with those hospitals. So probably we are looked upon as a company representatives, not as a molecular scientist at times. This is one point. The other point is that definitely it's more on the reactive basis. As you said, yes, clinicians do ask. They would like to have in-silo discussions also, like one-to-one on one reports, that we do on reactive basis, as well as we are trying to come up with a space where we can do it on a proactive basis. Because of many reasons, many clinicians may not have time to go on and to have a formal molecular tumor board, but on the fly, when they are talking to the patient, they just want to pick up a phone and talk to us like, what happened to this report? Or when we are sending a report out with a rare finding, we would like to, tell them, like I discussed that ALK case with you, and that
we
patient.
still are supposed to write it up.
Yeah,
It's
yeah,
still not written up.
and the another lab, I think, had given some bizarre result which was not matching with the clinical
Correct.
presentation
Exactly.
at all.
We would have treated that patient completely differently.
Completely differently. So that means that these interactions and discussions are helpful So molecular tumor boards are a platform, a formal platform that can be planned, but I feel that on the fly proactive discussions has to happen from the molecular scientists as well as from the clinicians, so that a gap has to bridge significantly.
I couldn't agree more on this. Yes, sir. Please.
Seventy Rakesh Jarali. So, my experience with neuro-oncology, as you know, in the last has been completely transformational. As for the last 5-7 years in particular, as compared to other tumors, not only has its therapeutic and predictive value, but also diagnostic value. So the latest WHO classification, CNS5, incorporates. So our tumor boards used to run for an hour or so. Now they are 2.5 hours. And we have a clinical genetist, we have a genetic counselor on board, and we now do Pan-Apollo twice a week from 9:30 to 12, Tuesdays and Fridays. But in order to bring the cost is again a volume game, as has been said. So I also feel that while you retain that leadership of precision oncology and the complexities of multi-omics, we realize the resistance mechanism and liquid biopsies and microenvironment. May I also provocately say that perhaps at some level we have to find what is called democratization of precision oncology. Democratization of molecular tumor boards. Let us not tell them molecular tumor boards because they are intimidating, and try to glean away the glamour component of it, such that it becomes mainstream. Which tumor board does not have molecular at the moment? And we are lucky that we have a molecular scientist joining online. But in future, in 5 to 10 to 15 years, globally, as well as in many parts of India, the message should be how to make it relatively simple, how to make it relatively accessible, such that this intimidating thing does not occur to a mainstream clinician as well as to the patients.
Wonderful thought. Actually, I wanted to come to you to ask how do you, what do you think of precision in brain tumors? And this has been your body of work, and you recognize globally for that. I couldn't agree with you more. And one of the reasons why I moved from one institution to the other 4 years ago was to scale up, to just let it flow, for it to go and be imbibed by 100 centers, 200 centers. Let it just go and become a routine, no longer remain a unique feature that could be with a halo. It shouldn't be that. Unless and until this is incorporated as a routine, we will not be able to see the light truly. So, couldn't agree with you more, sir. And I think the challenge will be to really scale up to that extent, make the tests, and it's never going to be a perfect world. So we have to function in an imperfect time with imperfect tests, with imperfect backing, with limitations that we have, but we are going to have to make it work. So we are completely out of time. I would like to finish with a couple of slides right here. India as a nation, so I borrow this slide from my AACR and UN presentation, where this red bar is all about people who are putting the bill through their personal pockets. And this graph is about the clinical trials, and we saw a whole lot of discussion happening regarding the clinical trials, so that's a beehive. I did not go there. But we know that for 1.5 billion people, 456 trials in 2023 is actually peanuts. So we need to come up with a hub and spoke model, and there may be hundreds of hubs that then collaborate with spokes all across the nation and facilitate not just testing, but therapy with the help of funding and with the help of clinical trials. I don't want to close this without a final word from our godfather here, Advani sir. we could kindly give a mic to Sir. I would just like to hear from him, hear from you, Sir. What are your thoughts regarding precision? And without your words, this is not going to be complete.
No, I think there's no question that the precision medicine, molecular analysis have played a major role in the last 10, 15 years, all the development that we have seen. But I think one thing which we should not forget, which I think sometimes we forget, because you get so much engrossed with the molecular thing only, that you forget too many things. Remember that the cancer is a multifactorial disease. It's not only in terms of the multiple genes, but multiple factors responsible for it. The multiple ways by which a normal cell is transformed to the cancer cells. And it's epigenetics, we as well know. We know also some diseases where there's no molecular defect and they have been cured with the disease. Look at the acute promyelocytic leukemia, arsenic trioxide, ATRA, they have changed the whole disease from incurable to the curable disease. So I think what I feel is that in all our passion for the precision medicine, we should not forget many other factors whenever we are looking at the patient and not look at one eye. We have to have, God has given us two eyes. So we have to keep our not only eyes, but the brain open to see that we can develop or do something better for our patient.
Amazing. Thank you for that wisdom, and thank you all. Thank you, my panelists, and thank you, audience, and thank you, organizers. Aju, especially, thank you for the opportunity.
Thank you all, and to present the memento, let me invite Dr. Nikhil Haridas and Dr. Akhil Santosh to the stage, please. Thank you, doctors. And now we are moving on to the scientific sessions where we'll be hearing from the lead experts on cutting-edge advancements in oncology. Firstly, we have a highly anticipated talk on CARTs and bispecifics, the next frontiers of oncology, exploring some of the most advanced and innovative treatment approaches emerging in cancer care. It's my pleasure to introduce a distinguished speaker for this session, Dr. Shaji Kumar. Dr. Shaji Kumar is a consultant in the Division of Hematology and Professor of Medicine in the Mayo Clinic in Rochester, widely recognized for his extensive research and clinical trials, focusing on novel therapies for multiple myeloma and other plasma cell disorders. Inviting Dr. Shaji Kumar to the dais.
All right, good morning, good afternoon almost. All right, I'll try and see if I can make up some time here. Looks like we are running behind on time here. So what I'm going to do is to focus initially on some of the, I think, most important advance in immunotherapy in the past decade, and has really changed the face of many of the diseases, particularly hematological malignancies. And that's the CAR-Ts and the bispecifics, and then talk maybe more specifically about what it has done for myeloma as an example of the power of immunotherapy. So my disclosures. So when you think about the timeline of immunotherapy, much has changed in the past half a century. So when you think about radiation and bone marrow transplant, we're talking about in the 50s and 60s, and then the whole concept of allogeneic transplant was essentially built on how the power of the T cells to get rid of the cancers. And since that time, it has gone through a lot of different evolution in terms of trying to, how can we harness the power of the T cells, whether it be, again, tumor infiltrating lymphocyte approaches as well as many of the others, and eventually culminating in what we are doing right now in the clinic, primarily in the form of CAR-Ts and bispecifics, but also tumor infiltrating lymphocytes and other modalities. So we're going to focus primarily on the T cells, CAR-T cells and bispecifics for this session. And when you think about the complex structure that you have for the T cells to recognize the tumor in the normal anti-tumor efficacy that happens innately, it's very complicated when you look at the T cell receptor structure and all the co-stimulatory signals that goes with it. And when you think about the receptor that is modified for the purpose of the CAR-T cell, you realize it's very simplified. You have a tumor-associated antigen recognition site, a transmembrane domain, and then basically a co-stimulatory domain, and of course the stimulatory apparatus that is inherently important for this T cell activation. And then you have obviously the whole bispecific approach, which again tries to use the innate T cells for anti-tumor activity without necessarily introducing any CAR-T cell modifications. So when you think about the CAR-T cell or the T cell strategies, we have gone from the kind of the non-selective or non-specific approaches to a more specific approach over the years. So we are very familiar with some of the technologies that we've been using for a while, including the donor lymphocyte infusion we use after allogeneic stem cell transplant, the lymphocyte activated T cells, as well as tumor infiltrating lymphocytes, all of which were trying to, again, harvest the T cell power, but not without the degree of specificity or anti-tumor targeting that would lead to the success that we have seen with CAR-T cell, where we have T cells that have receptors or engineered to express the receptors that are specifically targeting the tumor cell. So when you look at the CAR-T cell structure, and this diagram here kind of gives you a sense of how these things have evolved over the past 2 decades. They all have a binding domain, and that again gives us the opportunity to, if you think about it, the possibilities are limitless because there's so many permutations and combinations you can introduce into this structure, right? So you can have a variety of different binding domains, which can either be because of single chain fragments, you can have cytokines, nanobodies, ligands, a whole plethora of different things to specifically identify the target of interest. Some of the other things like the hinge, the transdomain area, as well as the stimulatory structure is essentially similar between all the different CAR-Ts we have. But the co-stimulatory molecules can vary, and this has been engineered to increase the efficacy of many of the CAR-Ts that we have right now. CD28, 41BB have been the kind of the foundation for many of these, but since then there have been a variety of other co-stimulatory domains that have been incorporated into the T cell receptor structure. And what is really, again, I think changing the whole field of CAR-T cell is what can happen beyond that stimulatory domain outside of just activating the T cells, right? How can we actually enhance the T cell response, so to speak? And that has involved secretion of a variety of different cytokines, which can, again, feed into a self-activation loop for any of these. There are approaches that are very novel that's looking at trying to make these cells secrete bispecific antibodies that then can amplify the whole T cell mediated anti-tumor efficacy. So again, there's a lot of work that's ongoing in terms of trying to enhance the CAR-Ts and develop the next generation of CAR-T cells for a variety of different cancers, including hematological malignancies and solid tumors. Now, another approach, and that is primarily has been driven by the fact that these are patients who needs therapy relatively fast, and the T cells often takes the CAR-T cells often take 4 to 6 weeks to create. There has been a sense of urgency. How can we get this treatment to the patients faster? So there have been a lot of interest in trying to develop off-the-shelf system, the best example of which is allogeneic CAR-T cells. There are clearly, certain differences in the techniques because some of the initial ones have used gene editing to get rid of the CD52 expression on these cells so that you can use anti-CD52 approaches for lymphodepletion that is needed prior to infusing the allogeneic CAR T cells. The advantages of allogeneic CAR T cell is often that you have a healthy T cell that, we know the patients on T cells obviously failed at doing the job of eradicating the tumor. Can we actually change that factor and introduce a totally healthy T cells? Obviously the advantage of off the shelf. The disadvantages have been the higher degree of lymphodepletion or the suppression, immunosuppression that is needed for the allogeneic CAR T cells, which in turn has led to quite a bit of problem with infections and so forth. So there's pros and cons to the whole concept of allogeneic CAR T cells. But what has been happening, I think, is that in the future, maybe we don't really have that degree of, the sense of having to use the CAR T cell right away is probably not going to be there for two reasons. One, these are going to be mainstream treatments that we are going to use before the patients are looking desperately for a last-ditch effort. So patients are going to be in a much better shape and can wait. And two, the manufacturing technologies are evolving. You can get your CAR T cells back in a week to 2 weeks now with some of the modern technologies. So I think many of the arguments in favor of allogeneic CAR T cells are fast disappearing. So I'm not sure this is really going to be a way of the future. We have also learned over times there are multiple different resistance mechanisms. Even with many of those highly sensitive cancers, they often become resistant to the CAR T cells. And a variety of different mechanisms play a role into it. There's clearly antigen loss that has been recorded in many different tumors. There's immunosuppression that happens with it. The tonic signaling leads to, again, energy in the T cells and T cell exhaustion. And there's a variety of other immunological mechanisms that lead to the T cell death. So there have been attempts to try and say how can we overcome some of these common mechanisms, right? And then they get reinfusion of the cells. Almost a 95% overall response rate with a very good partial response at 95% plus, with almost 80% of the patients being in complete response. And this is in a group of patients who are triple class refractory, median of 4 to 5 prior lines of therapy, a group of patients who are not expected to survive on an average beyond 11 months. And this is long-term data that was presented at ASCO this year from the 92 patients who are enrolled on the CARTITUDE-1 trial. 27 of those patients were still disease-free after their CAR T cell therapy without having received any additional therapy for the past 5 years. Yes, it's not 100%, but it's still a major improvement in this disease where maybe we are starting to see a flat line, but it's hard to say that because, again, all the censoring events there. But I think we have made dramatic progress for at least those patients who did not have any other treatments available at that point in time. And this is the overall survival for the same patient population. Now, the other CAR T we have, which is the ide-cel, it's again the initial trial, about 80% overall response rate. Many of these patients get to be minimal residual disease negative despite having failed all the other therapies having failed them before they got to this point. And so, the story continues. We have got multiple other new CAR T cells that are still in development. Many of them are targeting different antigens like GPRC5D and FCRH5 and SLAMF7. Some of them are targeting 2 different antigens, and hopefully this will make an impact as well. Now that we know that this is quite effective in the late line settings, should we be using it early on when the CAR T cells are maybe in a better shape? And that is, at least the in vitro data suggests that's what we should do. And this led to some of the trials like the CARTITUDE-4 trial where patients with 1 to 3 prior lines of therapy, they were randomized to getting standard of care treatment or cilta-cel. And the trial showed that using a CAR T cell significantly improved their progression-free survival. One might ask, why aren't we treating everybody who is relapsing first line with CAR T cell? Multiple challenges. One, of course, these therapies are not without toxicity. There can be significant neurological toxicity in some of these patients. So I don't think we are at a point where we can say everybody needs to be treated with CAR T at first relapse. But as the safety and the efficacy of these agents continue to improve, I can easily see that happening in the future. And probably not just in the first relapse, but maybe even before the first relapse. And this is the second phase 3 trial, the KarMMa-3 trial,
that showed that ide-cel is better than standard of care for patients with 2 to 4 prior lines of therapy. And then, this is starting to move ahead. Now, can we look at the first line? This is a cohort of patients who did not respond well to transplant. Can we give them CAR T-cell therapy and improve their outcome? And at least, again, short-term follow-up, it seems like we are able to get deep responses in these people who did not respond to transplant. Now, will these responses last? I think time will tell. There are obviously approaches to targeting different. This is another antigens. This is another CAR T-cell that is targeting GPRC5D, same target as talquetamab. And here again, the initial data looks very promising with an overall response rate close to 100%, and many of these patients actually having durable responses. There have been a lot of approaches trying to see, can we target 2 different antigens with CAR T-cell? This is an example of one of them that was actually developed in China targeting CD19 and BCMA. And they studied this in newly diagnosed myeloma patients and showing a 100% response rate. Again, increasing, push towards targeting multiple antigens, moving the CAR T cells early on in the course of therapy. So in the last few minutes, I just want to talk about the success with bispecific antibodies in myeloma. We have, as I said, 3 of them. The first one is teclistamab. This is a BCMA targeting bispecific antibody. Overall response rate is about 60% in a population that is very similar to what was studied in the CAR T setting, with a median PFS of about a year. Certainly these results are not quite as remarkable as what we saw with CAR T, where we saw 90+% response rate and PFS of almost 3 years. Here we are talking about a 60% response rate and 12-month PFS. Similar data with elranatamab, another BCMA targeting bispecific, 60% overall response rate. Median PFS is roughly about 18 months in this particular case. And then we have talquetamab, which again is a GPRC5D targeting bispecific antibody, 60-65% overall response rate, median PFS about 12 to 15 months. So one of the themes that is emerging from the bispecific antibody therapies is that it seems to be a lot more platform specific rather than really a target specific. The response rates across the board for all the bispecifics is about 60 to 70%, and the median PFS of about a year to year and a half. And then, of course, with talquetamab, there are certain specific toxicities. I won't go into too much detail, but something to keep in mind as we go from antigen to antigen, there can be some unique toxicities that becomes evident. For example, GPRC5D is expressed in a lot of different epidermal tissue, and that leads to a lot of skin toxicity, as well as oral mucosal toxicity that leads to taste changes. So how can we make these bispecific antibodies also better than what it is today? One option is to combine them with standard of care agents, and this is a study that was done looking at combining teclistamab with daratumumab and lenalidomide, 2 standard of care agents, and you can see that the response rates are now going from 60% to almost 90%. Similarly, you can see the same thing in the context of another combination, teclistamab, daratumumab, and pomalidomide in relapse patients, 94% overall response rate. And then we have talquetamab combined with daratumumab in relapse setting, a response rate of 84%. That's again improving upon that 60% we saw with single agent talquetamab. But what has really been interesting, and we see this with the Redirect 1 study where teclistamab was combined with talquetamab. So now you have 2 bispecifics, no standard of care agents, no chemotherapy, no steroids, and you're getting a response rate of almost 94% that is similar to what we saw with CAR T-cell therapy. So I think this is another way of, again, trying to capture that T-cell immune system's ability to eradicate the tumor. And we recently published some data with this combination in patients with extramedullary disease, which is a very difficult to control situation in myeloma setting. And the efficacy was much higher than what we have seen in the past. So we certainly have more questions and answers today with immunotherapies. With both CAR T cells and bispecific antibodies, we still have to define which patient population at what stage of the disease. And these questions are, I put it in the context of myeloma, but probably applies to everything. For example, in lymphoma, I think the CAR T cell therapies have literally displaced transplant from where it was being used. And I think we are certainly looking at that paradigm in the setting of myeloma in the next 5 years. Now, even when we have this plethora of different immunotherapy agents, should we be using CAR T first? Should we be using bispecifics first? Obviously, the cost is an important factor, but I do see CAR T cell therapy as a way to democratize immunotherapy, because that is something that anybody can make across the globe, as we have seen with the number of CAR T cells coming out of China. So I think that's an opportunity for us to really make a dramatic change in how we treat patients with cancer, and we should really take that opportunity and run with it because we have the necessary infrastructure in this country to do that. And then there's obviously a lot of questions that come up in terms of sequencing and targeting, and a lot of the discussions in the past session is germane to this as to identifying the right patient for the right immunotherapy. So how do we marry that precision medicine concept to the immunotherapy treatment concept? So with that, I'll stop, and thank you so much for attention.
Hello, sir. Yeah, I have two questions. And the first is about the allogenic CAR-T. Is it really promising as the early data shows actually the CAR-T persistence is very low when compared to autologous? What's your experience from clinical trials?
So, I have to say that I'm not yet convinced that allogeneic CAR-T is really going to make a huge impact, primarily because of the immunosuppression that goes with it. That is at least the experience so far that we have had with it. Now, having said that, if we can figure out some way of doing the lymphodepletion differently so that it doesn't lead to much more immunosuppression, maybe there's not. I mean, the healthy T cell part is very convincing, right? I mean, that is an advantage. But the question is, can we get away from the immunosuppression part? And so far the answer is no, but we'll
usually
see what it
GVHD prophylaxis is needed as exactly like an allogeneic stem cell transplantation, or?
Not quite as much, but it's still, the way we're using some of the anti-CD52 strategies that can lead to quite a bit of immunosuppression.
Yeah. Then about the anti-BCMA therapy in myeloma, we have the bispecific and the BCMA CAR-T. And how do sequences and if the patient already received teclistamab, what is the impact of CAR-T after that?
Yeah, so we have to take with the existing data with a grain of salt, because a lot of this has been generated in the context of very late stage disease where patients went from one therapy to the next very, very fast. So what we have learned is that if we use a CAR T cell after getting a bispecific antibody, the efficacy goes down from about 90% down to 50%. Whereas if you use the other way around, the bispecific activity goes down by maybe 10%. So I think our preference has been to use the CAR T first because one, it's expensive. We want to get the maximum benefit out of it. And then the bispecifics you can use any time, whereas the CAR T cell, there are other comorbidities and other limitations that happen. Now, having said that, we don't know what the future is going to be like. Let's say tomorrow we use teclistamab as part of the frontline therapy, and patients get a PFS of 10 years and they get a CAR T then, having not seen a bispecific for 9 years. Would it matter? We don't know.
Yeah, thank you.
Sir, what are your thoughts on the other cells that could be modulating the immune response from the stroma, for example, especially the cancer-associated fibroblasts, M2 macrophages, etc.? And how do you think these cells may be probably influencing the impact of the CAR-T or other immune therapies in general?
No, it's a very important question. I think we are learning more and more about how much the tumor microenvironment actually modulates the immunosuppression. So I think one key thing is we know that the fibroblasts or the stromal cells actually do secrete a variety of different cytokines that inhibit the T cell reaction to the antigen. So we have, many people are actually exploring CAR T cells that are targeting the fibroblasts at the same time as they're targeting the tumor cells in order to see if we can get away from that.
Can I ask you one question is about, is the autologous stem cell transplant out? Can we move the CAR T up front rather than keep it later?
No, I think it's an important question. I think, that's what, there are a couple of large phase 3 trials ongoing that are randomizing patients between getting a CAR T versus an auto transplant. The issue that I see right now is the toxicity with CAR T, especially some of those delayed neurological toxicity like Parkinson's. So if we have a therapy that, if you look at the Perseus trial with DRBD injection, transplant, and dual maintenance, the projected PFS there is 15 years. So if you have somebody who is 60 and you give them Parkinson in the first year of their myeloma diagnosis, that would be something very hard to live with. So I think there is still some caveats to using it upfront. But I think once we have safer CAR Ts, it'll move more and more upfront. And if you have patients who are high risk and we know they're not going to do well, then we are willing to take that extra risk.
Thank you. Thank you. I think we'll Thank you, Dr. Shaji, for that excellent talk.
Thank you, Doctor. And now delving into how innovative therapies are revolutionizing cancer treatment. Dr. Sabby George brings to us the science behind antibody-drug conjugates, game changers in oncology. Dr. Sabby George is a highly respected medical oncologist and researcher at the Roswell Park Comprehensive Cancer Center, known for his work in developing novel cancer therapies and his expertise in drug development and clinical trials. Inviting Dr. Sabby George to the dais.
Thank you. Again, for giving me the opportunity to talk about ADCs, or antibody-drug conjugates. These are, as Dr. Shaji Kumar mentioned, these are another, class of drugs which revolutionized the field here. These are my disclosures. So let's see what these are. So this is a light in the 17th floor of this building. How do you turn it off? There are a couple different ways, as I shown here. One way is to, turn off the main switch to the building, or main switch of the building, or turn off the transformer to the region, which is quite radical. And the second way is to, walk into the 17th floor, find that room, open the door, and find the right switch and turn it off. So those are two different ways of turning off that light, in the only light which is on in the building. So the antibody-drug conjugates is more of a targeted approach, delivering treatment to the appropriate cell, hitting the cancer cell, opposed to hitting the bystander cells, or by reducing toxicity. Thus, we can hit the target, achieve the result by reducing the collateral damage. So the chemotherapy approach is similar to the radical approach that we talked about earlier, turning off the whole building, and instead of turning off the switch in that room. So which may have a lot of side effects, which are not unwanted side effects, and due to the off-target effect. While targeted therapy examples are shown here, so monoclonal antibodies like bevacizumab and panitumumab, they achieve the targeted result by neutralizing antibodies. And likewise, the bispecific antibodies Dr. Shaji Kumar mentioned, I won't be going into any details of that. And the third one is the receptor tyrosine kinase inhibitors. They, like sunitinib, cabozantinib, a whole long list of tyrosine kinase inhibitors which can reduce the signaling of the cancer cell by attaching to the receptor tyrosine kinase on the cell surface and achieving cancer response and PFS benefit and survival advantage. And the last class, what I'm going to talk about is the ADC or antibody-drug conjugates. So the classic one is using the monoclonal antibody, and then the second one is using the small molecule that targets an epitope on the cancer surface. So ADC with chemotherapy payload, like enfortumab vedotin or sacituzumab govitecan, these are used in GU and breast cancer. This is more like a Trojan horse approach. So you have a drug that binds to the cell and delivers chemotherapy into the cell. I'm going to show a couple pictures in the coming slides. And so that's the chemotherapy payload. Next one is a small molecule with a radioligand, like the Pluvicto or PSMA 177 vipivotide tetraxetan. That's called the Pluvicto, used in treating prostate cancer patients. And so that uses a small molecule that binds to the PSMA ligand on the cell surface. So let's see how the antibody-drug conjugate is designed. So this is an antibody, fully human IgG1 kappa monoclonal antibody. This is the example of enfortumab vedotin here. And as you can see, see here, I don't think you can see my cursor. The protease, there is a linker that connects the chemotherapy payload to the antibody. So it's in this case, it's a protease cleavable linker. And then, so those are the aspects of, those are the elements of this ADC. And the chemotherapy payload is MMAE, or monomethyl auristatin E, which is a microtubule disrupting agent. So that's the design of enfortumab vedotin, which targets Nectin-4 on the cancer cells. Nectin-4 is expressed in bladder cancer cells and other normal cells like skin and salivary glands, etc. So let's see how this works. These are stepwise functioning of this ADC. Antibody drug conjugate is administered intravenously. And so the binding of ADC to Nectin-4 is shown by the one in the here. Number 1 represents the binding of ADC, this EV to the cell surface. And number 2 is the internalization of the ADC Nectin-4 complex. And then number 3 is the proteolytic cleavage, which allows for the release of MMAE into the cancer cell. I mean, the chemotherapy is released into the cancer cell, and thus, and number 4, it disrupts the microtubule and causes cell death, number 5. And cell dies and results in good result for the patient. Now, talking about the ADC, there are a couple important aspects of ADC which makes it safe and efficacious. So ADC has to be stable in the bloodstream, meaning the linker should not be cleaved before it gets to the cell, before it gets to the target. If it is cleaved and the chemotherapy is released into the bloodstream, it causes a lot of off-target effect. And while this is a drug, very good drug with a good stability, and I'm going to show a couple slides with data from a couple different trials. So EV301 was the first large trial. I was involved with the phase 1 trial of EV103, and 301 is the first large trial, which was the trial that randomized advanced refractory bladder cancer patients to receive either EV or chemotherapy. So you can see that the response rate, objective response rate, is 40% favoring EV versus 17% for chemotherapy. And the PFS advantage is shown here modest, but translated into overall survival advantage. This was the first trial to show survival advantage in the treatment refractory setting of bladder cancer, and thus led to the approval of enfortumab vedotin in refractory bladder cancer. And the toxicities are very unique also. As you could see, this is comparing enfortumab to chemotherapy. As in the red boxes, you could see that the toxicities like peripheral neuropathy, pruritus, and a maculopapular rash, which are commoner in the enfortumab because of the expression of Nectin-4 in those tissues. While the green box shows that bone marrow toxicity is seen more with chemotherapy, as I mentioned earlier, with a bombing approach or a lot of off-target effect. So similarly, EV302 is a large trial which was reported a year ago at the ESMO Congress by my colleague from London, Tom. This randomized frontline patients, treatment-naive bladder cancer, metastatic bladder cancer patients, to enfortumab vedotin plus pembrolizumab or chemotherapy. You could see that the response rate was nearly 69% favoring enfortumab, opposed to 55 in the chemotherapy arm. Not 55, actually 45 in the chemotherapy arm. And that led to PFS advantage and overall survival advantage, as you can see here. And I want to again point out the toxicity profile of EV arm compared to chemotherapy arm. As you could see in the red box again peripheral neuropathy, pruritus, alopecia, and rashes are more common in the EV plus pembro arm compared to chemotherapy, while the bone marrow toxicities are lesser in the EV arm, again because of the lack of off-targeting effect from this drug. So this is a good drug that does what it's supposed to do. And importantly, Nectin-4 is pretty much universally expressed in bladder cancer, so you don't really need a biomarker to tell you, which bladder cancer patients will benefit from this. So 70% response rate is pretty amazing in a solid tumor. Now let's shift gear and talk about the small molecule Pluvicto, which uses a theranostic approach. Theranostic approach is using a diagnostic nuclear medicine test to identify a marker on the cancer cell, which is PSMA in this case, PSMA expressing prostate cancer cells, and then using a therapeutic agent, which is a radioligand, RLT, radioligand therapy, with the Pluvicto. So the PSMA PET scan will tell us if it's a positive study or negative study. If there are a lot of PSMA negative lesions, they may not benefit from this based on the VISION trial. So then VISION trial randomized. So before going there, I'm going to talk a little bit more about this agent. So this PSMA targeting lutetium-177, this shows that the ligand binds to the PSMA is also attached to the 177, lutetium-177 radionucleotide. And this is a picture showing the bound version of Pluvicto on the PSMA on cancer cell surface. And in the vicinity, it can release the beta particles which can damage the cancer cells. And that translates into radiographic progression-free survival and overall survival, which led to the approval of this drug in nearly 3 years ago. And importantly, adverse events are consistent with bone marrow toxicity from all this, because most of the prostate cancer mets are in the bones. And now this is a picture which shows a PSMA PET scan on the left-hand side at baseline. This is from a real patient. And then in the middle, you could see the SPECT scan done after cycle 1 showing that it's hitting the target, meaning the sizes, you could see the sizes are pretty similar of that lesion, which is the retroperitoneal lymph node in this case. And after cycle 6 on the right-hand side, you could see that that lesion has become so small, consistent with a good response. And so that's a theranostic approach. Now, I want to share with you the experience of an ineffective antibody drug conjugate. I was involved with this trial, which was a phase 2 study of AGS-163F versus axitinib. AGF-163F is an antibody drug conjugate against ENPP3, or ectonucleotide pyrophosphatase phosphodiesterase 3, which is seen on kidney cancer cells. So this was tested in refractory kidney cancer patients, and the payload is a microtubule inhibitor called MMAF, monomethyl auristatin F. And ENPP3, as I mentioned, is abundantly seen in clear cell and non-clear cell cancer cells. But interestingly, the result was dismal. The PFS was favoring axitinib, and the OS is not different between the two arms. So why was that case? That's, you have a target, you have a cancer cell, you have a drug payload delivered into the cancer cell, but it did not work. Why? Because kidney cancer cell is notorious for not responding to chemotherapy. It's not a fast multiplying cells. Most of them are not. Maybe sarcomatoid cells are, or rhabdoid cells are, but vast majority of them are not. So it's important to make sure that you pick the right target. So these are some of the examples of ADCs in oncology use currently. Enfortumab, single agent or in combination with pembro, is used for bladder cancer. Sacituzumab, which was approved for bladder cancer, but they withdrew the drug from the market for bladder because of a negative phase 3 trial, but it's available for triple negative breast cancer. And Pluvicto and lutetium, again, targeting against neuroendocrine cancer cells. Then for breast cancer, targeting the HER2, we have adotrastuzumab emtansine and famtrastuzumab deruxtecan. Those two, I bet, those are being used here. I know some of the patients have received in India, so I don't know how commonly used this. For hematologic malignancies, gemtuzumab, ozogamicin, inotuzumab, and brentuximab vedotin, and polatuzumab. Polatuzumab, I think, was developed at Roswell Park, and last one targeting CD19. So these are some of the examples of ADCs in use, and I'm hoping that with the development and with the refinement of technology, they can develop better antibody drug conjugates and select the right patient with a biomarker-based approach so that the responses are better. Responses are long-lasting and durable. So instead of treating everybody and having 30% of the patients not getting the benefit. So in summary, ADC delivered drug into the cancer cells effectively in a targeted fashion. This targeted drug delivery system has demonstrated significant overall survival and survival advantage compared to traditional chemotherapy, which has more off-target effects also. The toxicity depends on the target location and distribution and payload used also. So about the payload also, I wanted to tell you a little bit more about this also. There are a lot of aspects of the payload. So the drug-antibody ratio is a factor in determining the effect and also the toxicity. And effectiveness depends on the nature of cancer cells also. As I mentioned in the RCC, which was ineffective. This was my hunch even when the trial was ongoing, but then it was proved over time that it was not going to work. And ADCs have definitely shifted the paradigm in oncology care. So with that, I would like to conclude, and I thought I gained a couple minutes for the last speaker. So thank you again. Happy to answer questions.
Sir, I'm sorry, I'm going to ask you 2-3 small questions. One, why is it that we use microtubule inhibitors and no other class generally as payload? Secondly, now that the ADCs are basically based on the expression of the protein rather than on the mutation per se, do you think it's time to shift to transcriptomic analysis, look for expression, look for targeted protein expression based on the transcriptomic filtering, and then, so shift from genomic mutation-based testing to transcriptomic-based testing?
Right, so to answer your first question, microtubule inhibitor is one of the kind of drugs used. So they use topoisomerase 2 also. So sacituzumab is a topoisomerase 1 inhibitor. And there are a few other kinds of drug, calicomycin and all that. So about transcriptomic analyses, when you talk about cancer, there's a lot of heterogeneity in the one tumor itself. You biopsy one tumor in the North Pole, South Pole, East, West, whichever part. They may have different types of mutations. And the expression of proteins may not be uniform on their surfaces. While if you're using antibody drug conjugate approach, you need to have a good epitope that can be targeted, or an antigen that can be targeted on the cancer cell surface. So I think for an antibody drug conjugate or a small molecule based delivery system, you know, it's important to make sure that it's expressed. It may or may not be, you know, mutated cell. Mutated cells may have the same thing also, but the machinery is different. So that's a great question.
Sabu sir, I have a comment. So whenever these new molecules come, we get very excited. At least I get excited. And I use it in my practice. But the results are quite underwhelming when we compare with most of the clinical trials. I know clinical trials are the ideal patient, so obviously you expect some underwhelming result. But still, accommodating for that as well, it becomes underwhelming. So I wonder, you know, even if we are trying to target, like Advani sir was talking about, there are too many things in a tumor environment that are contributing to the response rates. So how mature do you think is this field of ADC targeting? Or do you think we have more to see? Do you think combinations of ADC and immunotherapy may be an approach, and ADC and vascular endothelial growth factor targeting, those kind of studies, are they in the horizon?
Yeah, definitely. That's a great question. Matter of fact, I had met with a company to develop a new ADC at ASCO. So I can't tell you more about it, but so ADCs, the stability is an important factor. You know, like I mentioned earlier, there's a lot to talk about the drug itself, the engineering of the drug. You have to find the ideal target. You have to create the drug which will be stable in the blood, and it will be released only. The chemotherapy will be cleaved, or the linker will be cleaved only inside the cancer cells. Again, there are different ways of cleaving the linker. One is proteolytic kind of cleavage that's based on the cytoplasmic proteolysis. Or second one is hydrolysis. So there are many different kinds of you know, cleavage. And then stability and the kind of drug use. And of course, the kind of cancer cells targeted, like in the case of RCC. So there's a lot iterations, and I think a combination is also already here. EV-Pembro is a standard of care for advanced bladder cancer now, the first line, best result. So yeah, definitely there are a lot to improve. Once again, great question.
Thank you, Dr. Sabi, for that excellent talk. I think we'll move on to the last topic. I request Dr. Rakesh Jalali, sir.
Thank you, Doctor. And now moving forward. The future in radiation of oncology, innovations in particles and delivery. This session will shed light on the exciting advancement and cutting-edge techniques shaping the future of radiation therapy in cancer treatment. And we have Dr. Rakesh Jalali with us. He is a highly acclaimed radiation oncologist, currently the medical director and head of radiation oncology at Apollo Proton Cancer Center, Chennai. Over to him.
Thank you. I'd like to begin by expressing my deep gratitude to Dr. Aju Matthews, the organizers of this wonderful organization, Ampok, and the kind of conclave that you guys have devised. Very unique, and I hope more and more states and more regions take up such important issues for oncology community. I thoroughly enjoyed the whole morning today, and I hope to tell you a little bit about proton therapy and particle therapy in general, which Dr. Matthews asked me to speak about. We spoke a fair bit about the demographics, the oncology burden. We talked about the rising incidence and what a formidable disease still cancer is. But we also have to recognize there is also an increasing burden of long-term cancer survivors. As many as about 40 to 50% may be able to survive more than 10 years. And we have very good data from childhood cancer study, but also being extrapolated to AYA population, adolescent and young adults, but also in older patient populations in terms of their ability to live normally or survive normally as anyone else in the society. And there are challenges both from the medical point of view, but also from the social point of view. In the last 5 to 10 years, though, enhanced surgical skill, technology, we heard about robotics, the molecular signature-driven therapy. We had a fascinating discussion on personalized precision oncology, immuno-oncology, and the high-precision radiation, which I'm going to speak about a little bit. Eventually, the fulcrum, the balance has to be between achieving sustainable, durable, long-term survival and cure, vis-a-vis also of the high-quality survivorship, which I say it's not only the cure, but it's also the quality of cure. And we spoke about the modern cancer management based on precision oncology, personalized medicine, we talked about big data, we talked about CAR T-cell, radiomics, so on and so forth. And there somewhere also is the particle beam therapy, because of highly precise nature of its technology and the beam delivery around the tumor, has also been incorporated, embedded in the paradigm of precision medicine. And the beauty of proton therapy as compared to conventional X-ray photon therapy is that if you look at it, the conventional therapy goes, it deposits, it's stored, but you cannot control its exit. So it does exit through the normal structures, and unfortunately there's a fair bit of collateral damage which we witnessed in our day-to-day clinics. The particle beam therapy, particularly the proton, has a lower entrance beam than it because of its unique physical and biological advantages. It deposits its ionizing radiation potential exactly at one point, which is called Bragg peak, and William Bragg won the Nobel Prize out of it. And then we have this classic waterfall that there is literally no dose whatsoever beyond the tumor, or beyond the target, as we say, such that the exit dose does not exist. And that we have to exploit in the clinic as to how to overcome and how to optimize our radiation beams in such a way that we maximize our tumor control to the radiation dose to that point, to the target, while minimizing the side effect collateral damage to the healthy tissues. And that is how the whole principle of proton therapy came. Unfortunately, the earlier technology delivery were very cumbersome. It was actually a very old concept, 1990 eventually, the Mass General in 1970s, then Uppsala, and then PSI Zurich, and many centers in Japan incorporated it, but they were very cumbersome. We had this technology called passive scattering or passive scanning, where you needed lots of infrastructure. I remember the first time I went to Japan, the whole cyclotron to the beam delivery system was about 1.5 kilometers, and that needed a lot of manpower and many other cumbersome technologies. What we have to ask is the modern proton therapy, and that is a revolution in the last 10 to 15 years. Now we don't need all this hardware, we don't need very large setups. It's a little bit more than the photon, of course, but what we call image-guided pencil beam technology. Now the technology is like a laser pointer. It used to be like a torch where we used to conform the beams with lead apertures and tungsten alloys and so on and so forth, which we had a great difficulty to dispose, and also had neutron contamination. But the modern technology is image-guided. You precisely target and you track where the beam is going, and they are pencil beams, tiny beams, and with the help of the target, what we call intensity modulated proton therapy, like you have the intensity modulated radiation therapy, the IMRT being the standard, the IMPT is the standard, and you can do it very, very neatly. And in the last 10 to 12 years, most of the proton facilities in the world have switched over to what is called the original technology being image-guided pencil beam technology, and that's why you see a number of centers coming up with proton therapy. We call it spot by spot, line by line, layer by layer, creating this 3-dimensional, and nowadays we use the gating using 4-dimensional, very highly conformal dose distribution envelopes around the target. And you can see the results. This is the classic, for example, a sacral tumor, you have the VMAT, which is the standard of care. You have the helical tomotherapy and a craniospinal axis radiation. There's a lot of dose to there's the target dose, of course, in the red, but a lot of dose to the surrounding structures. And now if you look at the proton therapy, it's highly, highly conformal, spares the normal brain, spares the rectum, spares in a young child, spares the ovary or testes, for example, the femoral heads, and in the craniospinal axis, of course, completely sparing the base of the skull, the thyroid, the mucosa, the mediastinum, the heart, the gut, the gonads, and so on. And so therefore, there are the advantages of the proton. And it was essentially started as the pediatric cancers for obvious reasons. But gratifyingly, it has found a niche in other cancers as well. Thoracic cancers is the second or third cancer now being used in proton, at least in North America and so in other parts of the world. There is some data on the prostate cancer, sarcomas, some fascinating data on head and neck cancers, brain tumors, which is my field, and GI cancers. I'll touch upon each of them in the next few slides. We were lucky in India, in Apollo, to be the first center, although it takes several time, a lot of data. I was in Tata Memorial that time, and then in 2018, I joined Apollo from TMH in Mumbai. And then it goes through the whole process. The Atomic Energy Regulatory Board did not have any experience, so we had to go through this fairly long period of gestation before we could deliver finally the first proton beam therapy in the country, and this was commissioned in 2019. It's an IBA, state-of-the-art, modern, image-guided pencil beam technology, delivering highly conformal IMPT techniques. We started relatively low, you get only 8 hours in the machine, only on one room. Now we have 2 rooms. We also have a third option of a third room, essentially being a fixed room on research, but we're also thinking of treating now in the clinical side. We treat about 55 to 70 patients per day on these 2 rooms. I've completed 2,000 patients odd in the last 6-7 years. Our minimum age is 9-month-old child and maximum age is 91 years. The uptime is remarkable, 99%, which is not even seen in the photon world. We were having about 94 to 95%. The good chunk of the patients are neuro-oncology, both adults and peds, but you can see the spectrum in many other cancer sites as well. Another interesting aspect is the pediatric cancers comprise about 3 to 5% of all the cancers. If you incorporate the AYA population, maybe 10 to 15%. But in our center, the number of cases that they get in the pediatric and AYA is 24%, because they are the ones which would need the maximum, and this is also we have maintained over the last 6-7 years ever since we started. Now, there is a downside though. The initial setup is 15 times more, the maintenance is significantly higher, the electricity bill, the throughput is at the time half, you need much manpower. Therefore, it is very important to have temper the expectation and see where you want to do. And at the same time, the imaging, the checks, the target, the planning, evaluation, the QA, the treatment delivery, every single thing is many-fold more complex and time-consuming, and also needs meticulous care, because sometimes the brag peak, if you're not sure where it will end, it should not end in a normal structure. You can actually cause much more harm. And there's also some uncertainty as far as what's called range uncertainty. Therefore, you have to be extremely careful as to how to judiciously use this rather complex technology. So right from day one, we start our day early morning at 8 o'clock, what we call a proton peer review process. I started daily, what's called daily ISO-center meetings. The room is actually also called ISO-center. Every single target, every single plan, every single adaptation has to be approved by a separate peer group. And this comprises both the clinicians, the medical physicists, and the radiation technologists. The radiation technologists cannot actually export the plan to the machine unless it goes through the whole checklist, and our radiation therapist is been empowered to actually deny, even if anyone asks them to deviate the system. And I cannot explain to you how useful exercise this has been over the period of time, and we are actually still learning over the process. We are grateful to ASTRO, actually the American Society for Radiation Oncology, to come with these model policies, and the group 1 indications are where there is a fair amount of data with very good evidence, and they include many cancers, and the general cancers when there you have any form of immunological issues, but also the CNS tumors, the head and neck cancers, thoracic cancers, and there are many lists, and this has really helped us to incorporate that particular patient in our peer review process. We were very keen, and I enjoyed Dr. Moni Kurikos's fascinating talk on the research part of it. Maybe we spent too much time in Tata. So in our own humble way, we have managed for every single patient there's a clinical trial. We have now 19 clinical trials, although we are hardcore corporate hospital, so as to speak, and it's a combination of registry trials and with some a priori research question being asked in a prospective database. Our first proton therapy trial was on what we call wrapper protocol, and this was on adolescent and young adults, and we realized, for example, there was hardly any data on doing sedation and pediatric anesthesia. We were lucky to employ, even now, there are 3 pediatric anesthesiologists who who come every day. We have about 6 to 7 children every day. We start at 6:30 in the morning till 12 o'clock in the night. And then we have published the SOPs now actually for the world as to how to do the pediatric anesthesia for such children. We were told, I was told when we were training in 2017 to 19, that do not do craniospinal access because it's a very complex technology. The whole brain and the whole spine has to be treated with too much uncertainties for the first 6 months to a year. Our fourth patient was a CSI patient, 17-year-old boy, adolescent with complete response in a germinoma, intracranial germinoma. How could we deny? And then, not by design, by for some reason, we have now done 200 CSI patients, one of the largest in the world, in one center, and have somehow gained an international reputation such that people from all over the world actually come to our center to learn the nuances of CSI and published series of articles as both the dosimetric aspect, the clinical aspects, and this is an ongoing project looking at the neurocognition, neuroendocrine, growth retardation, all the side effects of a survivorship clinic, which we do every week, so as to gain a very useful insights for the data collection that we have in the country that was discussed earlier during the session. Classic skull-based chordoma, again, Dr. Korikos knows that it's a classic indication. And the reason is because the dose that you need for, in a rather complex site in the skull base, which is like a no man's, the head and neck and the neurosurgery domain, you need a very, very high dose, which you just cannot do with IMRT photon technology. But this is rather complex technology. You have to go as high as 76 gray, as we say, EQD2, and our data is quite helpful. And that brings me to the point that a single alone standalone proton center will not work. And that was my condition to the Apollo before I joined, that it has to have a comprehensive cancer center attached with it, and we were lucky to have it. We have, like a DMG approach in TMH, we have what we call 8 cancer management teams, and there are the people work, every single person has to work only on 1 or 2 CMTs. That is the whole ethos of the Proton Cancer Center. And the example here I quote is that 20% of our patients who come with a skull-based chordoma, having been operated before, sometimes even irradiated before, have to undergo another surgery. Many times there is a metal, so there needs to be a very good, a very collaboration, and we have an unbelievable skull-based team led by actually Naveen Hedley, who was trained in Amrita, and then of course with Dr. Ari Chako's team in CMC Vellore. And you can see this is our contribution to the international literature, where we showed that if you do not do surgery and there is a dosimetric compromise, there is where the patients fail, and this will help. This exemplifies the teamwork. It's not only one proton or one immuno-oncology or one target. It has to work as a symphony, as we know, all being oncologists. In TMH, we were lucky. I was lucky to lead this prospective trial. Was the largest, probably the largest study to have prospective 10-year outcome data. Came out 3-4 months ago, where we have shown first time ever in the world, and the St. Jude's has retrospective data. Ours is prospective data with 10-year tumor control of the entire cohort. This is with photon and survival exceeding 90%, and also in a randomized fashion showed high precision stereotactic radiation, significantly better with conventional radiotherapy, based on the earlier trial that we published in JAMA, looking at significant advantages in terms of neurocognition and neuroendocrine preservation for these young people. And therefore, we extrapolated now to the Proton series, and this is the first Indian series on Proton, where we showed that, I'm just looking at the time, so I have 5 minutes. So looking at the encouraging experience with our image-guided, and of course it's relatively small numbers with early follow-up, but that the follow-up is very good, except that you have to be very careful about the cyst. If the cyst changes little bit as compared to the photon, it's very extremely sensitive to the density of the material which you irradiate. A small, a half a millimeter dynamics in the cyst volume can completely perturb your doses. So you have to be very conscious, very mindful of the dynamics of the cyst changes, and that we do an every weekly MRI for these patients so as to have that confidence to adapt the radiation plan accordingly, conforming to the target volume that you do at the same time. Now, you also have to ensure quality of cure. This is this patient is just an example, and then we have several others who was again a germinoma. She had a relatively high risk of cognitive failure. I treated her like I think 5 years now ago, and you can see for some reason she just missed out on 7 marks. extremely good because you can spare the hippocampi so beautifully, which you just cannot do with photon. So all these patients who were hippocampus, the mesial temporal lobe, the frontal lobe, the limbic system are so critical in a developmental stage. And you can do that, and this girl has done extremely well academically, and you can show she is taller than me, has not had so far any endocrine failure, and we are very grateful for her success story, and there are, of course, many others. And one of the major advantages, of course, is the significant reduction of second cancers with proton. There's unequivocal data around the globe, especially with the IMPT technology as compared to the scatter technology. There's a huge reduction of the second cancers with proton, and that is not only in young people, and Dr. George is here, even in prostate cancer now people are saying if you treat a prostate cancer of 60 has still 20, 30 years to go, why should we subject them for second cancers? And therefore, there's a great deal of data on that as well. My colleague, Dr. Sapna Nangia, is the in charge of head and neck cancer management team, and we have shown leadership in oral cavity, as has been shown in surgical oncology, as well as in head and neck surgery, as well as in medical oncology, for example, from Dr. Patil's group. So oral cavity is our data generation. The West has hardly any oral cavity, we all know that. And the niche area that we have demonstrated in proton is what is called mucosal preservation with IMPT. Because you treat only on the one side, literally the center of the mucosa and the opposite side is completely spared, whether it is the salivary gland tumors, but also in the oral cavity. And there are a couple of clinical trials going on where we have shown, and there are 3-4 papers already on it, where there is significant advantages both dosimetrically, but also the patient-reported outcomes. And we have several trials looking at the patient report, the PROMs, which is a very important endpoint for proton and in general for all head and neck oncology, and we are excited about it, especially in the upper part of the head and neck, whether it is skull base, the sinuses, the tumors, and not so much perhaps in the larynx and hypopharynx. My colleague Dr. Srinivas looks at the thoracic cancers, and everyone again told us not to do the moving target in the first 2 years, but now we have a registry, it's called PROMO, proton therapy for moving targets, and again in lung cancer, esophagus, mediastinal tumors, he has demonstrated quite a bit of very good data. Dr. Advani may or may not remember this plan, but this was one of his patients from Mumbai, lung cancer, where we had to give radiation, and our radiation oncology colleague, Hinduja, he actually was prohibitive plan because of the breath hold, and we just could not deliver IMRT with significant doses to the heart and the lung. And then we did treat them with the proton, and even now in 2025, he's doing extremely well with hardly any pneumonitis. So these are again very success stories. Dr. Nangia also looks after breast cancer, and we think that breast cancer, especially the left side, with doses not only to the median dose to the heart, but also to all the major structures like LAD, is almost nil. And you can see the data from the 3D CRT, VMAT, TOMO, proton, and our own clinical experience being extremely rewarding so far in this cohort. And I have just a few slides more. And therefore, the improving survivorship in breast cancer, I mean, there is just some data from UK. One patient came and ran a campaign and came all the way, and it's now a good ambassador for us. Very fascinating to know GI cancers on the liver, difficult pancreas. Whenever you have large HCCs, which is not suitable for SBRT, can be considered for proton. There is a ProCube study which we do, what is called proton therapy PROs in prostate cancer, and Dr. Srinivas looks after it, and that trial is also being published, the first data, and now being done in the other parts. I argue that although there are needs and gaps in recent developments in LMICs, the cooperation of global cancer trials, and I just give a glimpse, and right from day -1, we were lucky to have, that was my condition, that there has to be a clinical research secretariat. We are lucky to have a reasonably small, but at least 2 or 3 dedicated people looking after all data generation and what we can do over a period of time. Health technology assessment, again, very important, and in pediatric cancers, head and neck cancers, left-sided breast cancers, although the initial investment is more, whether it is from the public or the man on the street or the private investor, doesn't matter. At the end of the day, you have to have the return out of it. That cuts across all, whether it is ADCs or immuno-oncology and CAR T-cell. At least in these 5 sites, based on very detailed Markov model cost-effectiveness ratios, actually proton therapy is cost-effective from the society perspective. And then you need education, and we are part of the education proton. We do the practicums every year. And the last 30 seconds is my interest in immuno-oncology. We have the next IOSI actually in January 23 to 24th in Chennai, and hope many of you will come to it. And I have been entrusted with the task of presidency of the IOSI now. And we have done some work on IOSI personally. We have tried to show the effect of lymphopenia in gliomas, and this was published last year. And there is also a concept of treating only half the tumor, doing as the antigen, the APCs, and triggering an immune response, and therefore not treat the entire tumor. It's a very innovative, very kind of controversial study, but then there are some people to do it. My last slide is this. Because of the particle beam therapy and the emerging radiation therapy paradigms, the whole world is looking at different. Currently, whether it is breast cancer, lung cancer, GI cancer, brain tumors, we are obsessed with dose escalation, one dose fit all, irradiate large volumes, prophylactic lymph node irradiation. In this pelvis context, whole pelvis, standard DVH, and includes systemic agents like chemotherapy. The future perhaps is dose desescalation. Do not treat all the lymph nodes. Keep the lymphocytes. Preserve the microbiome. Preserve not only the GI, the head and neck microbiome. Keep the mediastinum, keep the Walder's ring there. Spare the lymph nodes. Spare the small and large bowel. You have to completely revolutionize how we look at the dose distributions and avoid as much as possible the systemic chemotherapy. And maybe this is one of the things to do, at least in some complex sites. With that, I thank and acknowledge all the team members in Apollo Group who have been part of our journey, and I thank you all for your patient listening. Thank you.
Request Senior Radiation Oncologist Dr. T.K. Padmanabhan sir to please come forward to hand over the memento to Dr. Rakesh Jalali. Thank you, doctors. Art speaks where words are unable to explain, and today we are truly privileged to be in the presence of a legend whose art has spoken volumes over decades. Ladies and gentlemen, it's an honor to welcome the legendary artist Sri B D Dethan, a name that shines bright in the world of art and culture. His vision, his strokes, and his deep connection with Kerala's soul have inspired generations. Yesterday, right here in this conclave, we have witnessed a moment of magic as Sri Dethan sir painted live in front of us, capturing the spirit of conclave on the canvas. And now we are proud to share that Ampok is humbled and honored to purchase this beautiful live painting, adding it to their treasured collection of cultural heritage. And that's not all. As a token of deep respect and admiration, Ampok would like to honor Sri B D Dethan sir with a ponnada, symbolizing our heartfelt gratitude for his contributions to the world of art. Thank you, sir, for gracing us with your presence and your art. Thank you, and a kind reminder to our esteemed delegates. We request you to please complete your checkout formalities at the earliest and kindly keep your luggage safely in the lobby area. And once you're done with that, you're invited to proceed for lunch, which is being served. Thank you all for your cooperation and gracious presence throughout the conclave.
Thank you all. With that, we conclude Kerala Cancer Conclave 2025. It has been a great journey for us. As I mentioned in the inaugural speech, the journey started in 2018. It has been of so much amount of struggles we had, right from the inspection. We had to do everything. We planned it such a way that the meeting happens in 2020. But unfortunately, due to COVID, we couldn't do it at that time. But then subsequently, as time passed, we evolved, and finally we are here. So from whatever discussions I had with my colleagues and other people, we are very happy that we were able to achieve what we actually aimed for. People like S.H. Advani sir, the senior most medical oncologist in the country, Professor Padmanabhan sir, whom is the father of what I would say, the father of modern radiation oncology, was also here. Dr. Shaji Kumar came all the way from Mayo Clinic only to be part of this event. So is Dr. Sabi. Many other people, doctors like Chris Booth, everybody joined us online. And many people were able to get in some of the best brains, best figures in the country who are actually experts in their respective field. So it was a totally unique meeting, totally a different meeting. So it was associated with so much amount of challenges, but Ampok as an association, I'm very proud to say that because of the support of all the members at Ampok, we were able to put up a great show, and what we actually aimed for, the dream of an Ampok project, has been implemented today. So I would like to thank each and every one of you at Ampok for the unconditional support that was extended to me right from day one. People have traveled across the country, across the globe to be part of this event. I remember Advani sir, he wanted to be part of this event, so he ensured that, and it is not that he just came for his session and went. The only person whom I can say that the person who stood right from day one, the first session till the last session, is Advani sir. If at this age, despite his whatever age, and the other limitations, if sir can be here, he is actually setting the role model which the youngsters should follow. You just come for the meeting, be part of the entire meeting. Don't be part of that session and then leave off. You should be, if you're part of a conclave or a part of any meeting, be part of that thing. So Advani sir, even at this age, he is setting us that example, which I feel that youngsters should also follow. So thank you, sir, for being part of this occasion, sir. I would like to thank each and every one of our faculties who have attended. I mean, as I mentioned, people have traveled from US, people have traveled from Middle East, people have traveled from North India, places like Raipur where we don't have a direct access. It was even difficult for them to come. People have traveled from Raipur to Delhi, Delhi to Mumbai, Mumbai to Trivandrum to be part of this conclave. I'm not naming them individually. I know that the amount of sacrifices people have made. There are persons who have traveled from China to Delhi, Delhi to Trivandrum to be part of this event. People have traveled from Chandigarh to Mumbai, Mumbai to Trivandrum to be part of this event. So I am very thankful to each and every one of them for making this event a grand success. I would like to thank my friends in the media for that extensive coverage which was provided to this cancer conclave. I know this was a meeting which we wanted to reach out to the public, so without a good media support, without a good media presence, it won't have been possible. So I'm very happy to say that the media supported us very well. The visual media, the print media, and the social media supported us to a large extent, in such a way that we got the visibility that we, which we actually wanted. And finally, a word to our supporters. People have supported us from the industry, the pharma industry. People have supported us from the hospital industry. So each and everyone wanted to be part of this event. So I'm thanking each and every one of the people who have actually supported and to make this event a great success. As I mentioned earlier in one of the presentations, Ampok is continuing this event. So this is, people may say that, okay, people have done multiple meetings like that. So this conclave, I can assure you, is that is going to be a continuous process. So Kerala Cancer Conclave 2.0 will happen in 2027 December. So I can assure you that by that time, we will come out with a different thing. Even for this project, with the help, Aju, yeah, please. Aju, when we were able to do some good clinical work, we have started doing some epidemiological work, and Ampok as an association has been supporting our members for clinical research also. Small steps when compared to what Dr. Shaji and other people are doing there, it might look very, very simple, but then the small steps are the one that is actually going to take us to the bigger thing. So Ampok as an association is going to play a significant role in the efforts which we are actually planning, and I need the support of each and every one of you in this endeavor. So thank you once again for being part of this Kerala Cancer Conclave. Thank you.
I would like to, I would like to request everyone to just stand up and give him a standing ovation. This is some sort of unconventional conference. I don't think any of the oncology people here would have attended something like this exclusively for 2 days. So I think it was all a dream by Boban, well executed by a team and headed by Aju. And I think both of them, We have to give it. Wonderful. Thank you.
Thank you all. As we conclude, let's remember this may be the end of Kerala Cancer Conclave, but it's the beginning of many collaborations, continued action, renewed commitment to a cancer-free tomorrow. Wishing everyone a safe travel, good health and unshaken hope. Thank you everyone. A kind reminder to all our esteemed delegates, we request you to please complete your checkout formalities at the earliest and keep your luggage safely in the lobby area. Once you're done with that, you're warmly invited to proceed for lunch. Thank you all.